Hi, everyone. Welcome to Dental CE Academy. It is March 2nd, 2024, and this is infection control in dental settings. I'm Dr. Kroling. I am the Chief Education Officer here at Dental CE Academy. I'm a public health dentist here in Phoenix, Arizona. I was the chief for the Office of Oral Health for Maricopa County's Public Health Department. And from time to time, I would be asked to accompany our state dental board to inspect dental practices that were on the receiving end of some sort of allegation or complaint. I'll be sharing some of those experiences with you and others. I started in the field of dentistry in 1981 as a registered dental assistant. I was a teenager at the time, and then attended the University of California, San Francisco School of Dentistry. And I was on the campus from 1989 to 95, including my dental school career as well as research that I was involved with. And it was during the time of the AIDS epidemic. So we're going to talk about how infection control has changed over the years, what have been the game changers for us. I'll be giving you quite a bit of information today and a lot of practical information, I think, that you can take back to your practices Monday and easily implement. Now, this course does align with the CDC guidelines for infection control in dental settings. However, I will be adding my own information as practical experience. I make this interactive, so let's go ahead and get started. I advise that you use Chrome browser for one. If you're using another browser, you may experience audio-video issues. And if you do, you can also log out and log back in. Our course today has been sponsored by Aerosol Assist Pivatool, and we thank them. They've sponsored so many of our infection control classes. And I've not received a speaker's honorarium, and I have no financial affiliation with the sponsor. I am an employee of Dental CE Academy. There is our agenda today. So the part one is from 8 until 9:30. At 9:30, Aerosol Assist will join us. Dr. Arguello, who is the founder and the inventor of the Aerosol Assist, for our break, which is a product demonstration, and it is not required for CE credit. So don't log out, but if you want to grab a cup of coffee, that's fine. If you want to learn more about aerosol and how to treat the aerosol in the patient zone, this is a great demonstration. Part two, we'll pick it up at 10 to 11:30. We will end at 11:30 Pacific time. You do have to be in attendance for part one and part two. At 11:30 Pacific time, I'll be redirecting all of you to complete a quiz online with me. All right, so please be in attendance here. You'll need 80% minimum passing score. You'll have unlimited attempts and then 1 week to complete. We'll send a reminder email later on today with the quiz, but I do need you all here at the end so that you'll get credit and to take the quiz online. Any questions about how to get your CE credit? Christina, I don't know how I have all the time, but I just love what I do, so thank you. Okay, so lots of hellos here, and I'm not going to be able to share them all, but I welcome you all here. And if you have any questions, please let us know. For those of you watching the recording later, here's how you'll get CE credit. Scroll below the video player here to the instructions section. Download the handout, which is number 2, and complete the quiz from the website, which is number 3. And that is for on-demand continuing education credit. All of the learning objectives are in your handout. There's a lot of information here. I would like to say that part 1, unfortunately, is a little bit on the dry side because of all the CDC information, but I'm going to try to make it as lively as possible. Part 2 is when we get into the nitty-gritty of sterilization and so forth. Question here, are we going to get CE through email? Yes. So once you complete the quiz online today, you'll get your CE certificate sent to your email within 5 to 10 minutes. Again, you need to be here at the end, definitely, so you can take that quiz. I'm going to prime you through the whole event here so that you shouldn't have any issue at the end. If you're not here, if you're at a soccer game, you're going to struggle. All right, so make sure that you're here and you're on a good connection. Okay, so why is infection control important for those of us? If we think about dentistry relative to medicine, dentistry is entirely procedural. We're setting up tray setups all day long. We have to be concerned about sterile instrument cassettes, packets, and so forth. We're concerned about cross-contamination or the potential for such because it is procedural. And we're exposed to aerosol. When you go to your physician right now, your medical doctor enters the room and will sit about 15 feet away from you, right? Ask you a few questions, type into a laptop, order some labs, order your prescription, and then that's it. They may do some hands-on evaluation, whatever the reason is that you're there, but they're gone, right? They're not exposed to the level of aerosol we are. They're not doing tray setups and procedures all day long, depending on their focus. So that's a concern that we have. And there's great potential when things go awry or you let your guard down for somebody to get very, very ill. And we're going to talk about those things today. Not only that, there's great potential for you to take some of these pathogens home with you. They don't just stay in the dental practice. So you can actually expose family members or whoever you live with. So patients and dental healthcare personnel are exposed to pathogens all day long. We come into contact with blood, oral respiratory secretions, aerosol, contaminated equipment, and we have to have proper procedures and protocols in place to prevent the transmission of infections among our patients and our staff. Again, if you experience any audio issues today, we have an engineer on every one of our courses. It would be on your end, or if we're having an outage, we're going to let you know. Be sure you're using Chrome browser. If you do experience this, you're on a phone, for instance, and you're moving, not much we can do for you there. But you can try logging out and logging back in. All right, in the United States, an estimated 9 million persons work in healthcare professions. And we've got the breakdown for you. Notice dental assistants rise at the top here. We have to be concerned about various pathogens, bacteria, viruses, oftentimes respiratory, but cytomegalovirus, which I don't think you all hear too much about anymore, but it was a real concern when I was training because AIDS patients would have reactivated cytomegalovirus, and it could cause all sorts of issues, brain issues as well. Hepatitis B, hepatitis C virus, herpes simplex virus types 1 and 2, HIV, Mycobacterium tuberculosis that we'll hear about, non-Mycobacterium tuberculosis that infects water lines, for instance, Staphylococci, Streptococci, SARS-CoV-2, SARS-CoV-1, other viruses and bacteria that colonize or infect the oral cavity and the respiratory tract. We also need to be worried about pathogens that are transmitted through the oral fecal route. And you might say, well, Dr. Kroling, that we don't really deal with the fecal route, right? Well, no, we do because of cross-contamination, because those pathogens oftentimes are transmitted through dirty hands, especially in a healthcare setting, which is why it's so critical for you to make sure you're washing your hands as well. If you have any questions along the way, please type them in the chat area for me. So the first influenza pandemic of the 21st century was what was called initially the swine flu. It was H1N1. April of 2009, I have a personal experience with H1N1. I became infected in a public health clinic where I was providing the majority of the pediatric care. And a lot of these children were away on spring break, and they came back and brought H1N1 with them from Mexico and so forth. And I became infected. I was very ill for about 6 weeks, and I was quarantined by our public health department, which is no Not much fun because it was prior to Instacart, so I had no food in the house. I'd have friends drop food off about 100 feet from my door. They sent someone out to the house, in a spacesuit to swab me. And of course, it came back. And it took 21 days at that time for the CDC to come back with a positive test. So in the meantime, I was put on Tamiflu. And that was, again, April 2009, our first influenza pandemic of the 21st century. Okay, modes of transmission here. We're going to talk about the chain of infection, but direct contact with the patient with blood or other body fluids, saliva, etc. Indirect contact with a contaminated instrument or contaminated surface. We call inanimate objects in terms of transmission fomites. So you might hear me say fomite. We're talking about an inanimate object with the potential to transmit infection or disease. Contact with the mucosa, the eyes, nose, and mouth, with droplets or spatter, the larger particles. Inhalation of aerosol, and the very small ultrafine particles that we have to be worried about because they remain suspended in our operatories and in our entire practice, actually, for hours at a time. Okay, we're going to talk now about the chain of infection, and you're going to see this probably the first question on your quiz. So hopefully you're here and you're able to hear me. So chain of infection, I'm going to go right to the graphic because it makes more sense. If you think of a chain around your neck, the only way it works is to keep those links intact, right? If the chain breaks, the chain doesn't function anymore. It's the same thing with the chain of infection. Now, half of you are going to get that question wrong. So I want to make sure, and it's not a trick question. We want to disrupt one or more of the links in this chain of infection to prevent disease transmission. All right, one or more of these links. And we start with the pathogen. So the pathogen would be the bacteria, the virus, fungi, in cases parasites. We need a reservoir. So that's where the host would come in. So it could be people, humans, soil, food, water. We need a portal of exit, a way for that pathogen to escape its reservoir from its host and be able to enter into another reservoir, right? So that can be through coughing, sneezing, bodily secretions, and feces. And then we need a mode of transmission. This is a way to transport or help that pathogen get to its new reservoir. And that can be through direct contact with the patient, indirect contact with contaminated surfaces, aerosol, etc., and then vectors. And notice the hands in that link are the #1 mode of transmission. Let me make that very clear. Your hands in your dental practice are the #1 mode of transmission of disease transmission, right? This is a problem because many of us believe when we wear gloves, we're protecting ourselves and our patients. Not necessarily so. You still have to wash your hands before you put your gloves on and after you take your gloves off. Also, many of you, and this is a very good practice, will have your patients wash their hands when they enter the operatory, right? That's a very good practice because patients bring in pathogens on their hands as well. Okay, portal of entry. This is the new host, right? And this is how these pathogens enter the new host, the mouth, the nose, eyes, or cuts in your skin, and then susceptible host. We need someone who is not immune to the infection that is caused or the disease caused by this pathogen. So it could really be anyone, right? And bacteria and viruses work in different ways. We certainly learned that currently with SARS-CoV-2 and all the mutations, right? But we have populations that are at greater risk. And how do we address those in our dental practice? We have, of course, our older adults over the age of 65 that are at greater risk for developing infection because the immune system is like a battery. Over time, It doesn't fire like it used to when you were in your early 20s, unfortunately. Infants who can be exposed but not have an immune system that's mature yet. So they may not have the force shield, if you will, to be able to prevent infection. RSV right now, which has been an issue, especially this year, oftentimes it is an infection of infants, and then they transmit it. And if grandma's taking care of them, grandma can end up with some issues, hospitalized and even death. And then again, immunocompromised patients, because they may be on medications and it suppresses their immune response. So if those populations come into a situation where there is contamination, they may not have the defense that someone who's younger and healthier will. Okay, so again, disease transmission prevented by interfering with one or more of the links in the chain of infection. Again, we spoke about the reservoir. Today we'll be speaking primarily about human reservoirs. And many common infectious diseases have human reservoirs. Okay, these are diseases that are transmitted from person to person, and humans are the intermediary. So this includes sexually transmitted diseases, measles, mumps, as well as streptococcal infections, many of the respiratory pathogens. An example would be smallpox virus, which was the reservoir. Humans were the reservoir for the smallpox virus. And so many of us boomers are vaccinated for smallpox, right? We have the scar on the arm, so we can't really lie about our age. And that was the first vaccine effort to eradicate a disease, and we completely wiped smallpox off the face of the earth. Children at that time, before you could start kindergarten, we had to be taken for this particular vaccine, which was a live virus, by the way, injected into the arm, and then it would create this sort of bullous lesion, and then it would scab over, and you couldn't touch your eyes or any place else. You couldn't scratch it, for instance, because it was live virus. And then your parents would get a card, and they would look at the level of healing. There would be photos of the scab and days, that were associated with that healing process. So it was a big deal. And parents around the world were relieved that we had the ability to save children's lives, because smallpox killed children at the time. So we don't have smallpox, as far as we know, on the earth anymore. Now we have mpox, monkeypox, which is also an orthopox virus. That's a course that I present. It's available on demand. Okay, human reservoirs. We have to be concerned in dentistry about what? In dentistry, we have carriers that can walk through our door of our practice with really any sort of infection on board, and they're not aware of it. They have no signs or symptoms, and they may check off no on their health history form. And you look at the health history form and you say, oh, they look pretty healthy. Look, they're fine. The problem is that they don't know that they are, quote, a carrier of a disease or infection, right? So they may or may not show the effects of illness. And that person is asymptomatic and capable of transmitting that pathogen to you and others in your practice. And we have different types of human carriers. We have the asymptomatic or passive, or what is called healthy carriers, never experience symptoms, but they're infected. Incubatory carriers are those that can still transmit the pathogen, but it's before they have any signs of clinical illness. So if you look at those first two, we can apply that to SARS-CoV-2, because you have patients walking in your practice right now. They're positive. They don't feel ill at all, but they're capable of transmitting that pathogen to you, right? Through respiratory, tidal volume breathing even. Incubatory carriers, again, you certainly have a lot of patients with SARS-CoV-2 that haven't experienced their clinical signs yet, but in that prodromal phase are still able to transmit the infection to others, because the virus is residing in the nasopharyngeal area and oropharyngeal area. All right, convalescent carriers. Those are folks that were infected, they've recovered from their illness, but they're still capable of transmitting the pathogens to others, right? I'm an example of a convalescent carrier or a chronic carrier. Sometimes there's overlap because I had C. difficile, Clostridium difficile came up on my 2-year anniversary, and I can shed spores, Clostridium difficile spores, for the rest of my life. So I have to take extra precautions in my home, at work, and so forth. You have patients that may be shedding Clostridium difficile spores in your practice right now, or employees. It's very common. Unfortunately, as you'll see, we are not using disinfectants to kill those spores, and those spores are very difficult to kill. They will live forever. So something that we will address today, especially because we are prescribers. So chronic carriers, again, are those that continue to harbor the pathogen, like hepatitis B or Salmonella typhi, for months or even years after their initial infection. And you can certainly have a combination of the above. So Typhoid Mary, that you've probably heard of before, was a cook in New York, and she unintentionally infected people in New York City. So at that time, public health, you want to complain about social distancing. Here's what public health would do. They would put you off on an island somewhere to separate you from the rest of society, right? So she was isolated on an island in the East River and died 25 years later. There's another famous story about the island of Molokai, right, off one of the Hawaiian islands. And the island of Molokai was used to banish patients that had Hansen's disease, or what is called leprosy. So they would be put on a ship, and the captain would take them to the island, drop them off in the ocean, and they'd have to swim to shore because the captain was afraid to go to the island. So those patients that made it would get to an island where there were no resources for them, no running water, nothing. And Father Damien from Belgium was sent to the island of Molokai to take care of these people, where he built water cisterns and churches and so forth. It's a very famous book. If you've not read it, it's a beautiful island. I had the ability to tour there several years ago, and you could only get there to the area of the island where the patients were, now called former patients because we have a cure, but you could only fly in there in a little prop plane, or you had to get on a mule and take a mule down a 3-mile sea cliff wall, which was what I took to get down to the area to tour. And there's a little post office there. Their food and supplies come in from Maui, etc. So it's an interesting story. Now is a national park here in the US. It's the most pristine island in Hawaii. Mandy said she's been there. Question here, how do you know if you are a convalescent carrier? Do they have to keep testing for anyone who had C. diff? So unfortunately, the testing's not always 100% if you're a carrier of C. diff, Sarah. So the way they would determine is test its stool sample. And then if you test positive for C. diff, but you're not producing toxins, the likelihood is that you are a carrier. But that's different than shedding spores. You may or may not be shedding spores, right? So the assumption is, for most people that have had C. difficile, as we'll see, we're probably carriers now. But carriers of C. difficile in the general population represent about 0.4 to 15%. So the 15% would be someone like me, or someone who's had a long-term stay in a hospital or a nursing home. Relatively 0.4% of the population's not much. So how do these patients really get C. difficile? Oftentimes, it's contamination in the healthcare environment coupled with antibiotics. And that's a course that I present. But I'll be showing you a video here in a little bit, and it talks about disinfection and the challenges we have, because Clostridium difficile is one of the top 4 CDC classified urgent threats, antimicrobial urgent threats. Half the cases of C. difficile, which there are 500,000 in a year, nearly half of them are antimicrobial resistant, which is what happened to me. So that means there's no cure. And of the 30,000 deaths, about half of those deaths are antibiotic resistant or caused by antibiotic resistance. So it's a huge issue. Their office manager had C. diff and it was a big scare. Yeah, it's a big scare. And I'll be talking about C. diff in some as we get a little further along. Would the term be subclinical? So subclinical often means that you do have some clinical signs, but they're not full-blown illness. Is this the same course that was presented on May the 6th? I don't have my calendar in front of me, but if you took it and it was 3 hours, yes, this is the same course. Okay. So again, carriers, I emphasize why, because this is what we're concerned about. The folks that are coming into our practice, they look fine. You let your guard down, or you're not using disinfectants properly or using the right disinfectants. Aerosol is abound, and that's the perfect storm. It can make you ill. Again, you can take these pathogens home with you. C. difficile travels with you, unfortunately. And if it sounds scary, it should be. It should sound scary. Animal reservoirs here, we're not going to get into too much detail, but we know certainly SARS-CoV-2 is thought to be from bats, West Nile from birds, Mpox from prairie dogs that were imported as pets. Environmental reservoirs, we've got fungal infections that we have to worry about that can be spread through the air here. In the Southwest Phoenix, we're always worried about valley fever, which is Coccidioides immitis, and it is in the droppings, bird droppings, that are spread through the dust. So when we have a major dust storm, big alert, we have valley fever clinics all over the Phoenix area. That tells you the level of it. Dogs get it, pets get it as well, because they're close to the ground and they're inhaling and they're licking everything. Legionnaire's disease, which is fungal, it's traced to water, often air conditioners that haven't been cleaned in some time. Sarah said her sister had C. difficile from antibiotic use, and she was only 24 years old at the time. Scary stuff. Yep, I hope I'll impress upon y'all today that Clostridium difficile, and again, I don't want to get too sidelined here, but Clostridium difficile, you're in an occupation of occupational exposure and risk. If you take an antibiotic for a sinus infection or a UTI, and you're working in a healthcare environment, because we know healthcare environments have a greater level of Clostridium difficile contamination than non-healthcare environments. But C. diff spores are everywhere in the natural environment as well. So in our practices, and you'll see a video that I'll show, and they call out dental practices. Dental practices are not immune from C. difficile spores. The problem we have is that we prescribe antibiotics and we invite the patient back for a root canal or an extraction or post-operative check, and we're inviting them back into a contaminated environment. So the educational process about C. difficile in dentistry is sorely lacking. And I'm now a national speaker based on surviving Clostridium difficile that followed a dental procedure and antibiotics. And I almost died. So I had to have a fecal transplant to save my life. And that story is another class that I present. But we'll talk about it in some more detail here, because it's important for you all to know that if you believe you have a concern, you need to do something about it and change how you're disinfecting your dental practices. And it's not more arduous to implement a few things, actually, it's much more simpler and it's going to be safer for all of you. All right, the portal of exit, that's how the pathogen will leave the host, and it usually corresponds to the site where it was localized to begin with. And there are examples here. So definitely the respiratory viruses and so forth will exit the respiratory tract and usually re-enter someone else's respiratory tract. Clostridium difficile, of course, exits via feces, but is most of the time transmitted through cross-contamination, dirty hands. Dirty hands. So if somebody who has dirty hands touches your doorknob or your ATM machine or whatever, and you're not washing your hands, there's a problem. But also, just as an aside, C. diff spores live on shoes, they live on clothing, the laundry situation. In my case, I had to have a biohazard team to come into my home to completely mitigate my home with C. difficile spores so that I didn't reinfect myself or my pets. It's a huge issue. Okay, bloodborne agents, of course, can exit the placenta, mother to fetus. We know syphilis, rubella, and so forth. And of course, others can be transmitted through the cuts or needles in the skin. So if your skin is not intact, that can be a risk factor for you. All right, modes of transmission, direct and indirect. So direct transmission, this is the pathogen transmitted from its reservoir to a susceptible host. So direct patient contact or droplet spread. So the droplets are the very large particles, actually spatter when you are face down working on that patient. Those big particles are hitting you and they're bouncing off your face shield, they're bouncing off your arms, etc. They're bouncing around in the operatory until they finally come to earth, and they may settle where? On your floor, on the patient tray, in your hair if it's not covered, on your forearms if they're not covered. So indirect transmission is aerosol. Also, it's vehicle-borne. When we talk about vehicle-borne, we're talking about instruments that are not sterilized or countertops that are not disinfected and so forth. All right, direct transmission is through direct contact with the patient again, and indirect is exactly that. So direct contact can include the droplet spread as well as what we call spatter. So droplets are the smaller particles, but depending on their size, it will tell us how far they travel. And we'll talk about aerosol in a little bit more detail as we move on. And there's a course that I present on aerosol as well. And indirect transmission, certainly aerosol, so suspended air particles, vehicles on inanimate objects, instruments, countertops, and then vectors. So when we talk about aerosol here, we're talking about aerosol. We have to address it in two ways. One is in the zones. So there's the patient zone, which is closest to the patient's oral cavity in your faces. There is what I call the operatory zone, so 6 to 8 feet around the patient. And then we have the entire facility that has to be addressed, because we have aerosol that doesn't just stay in the operatory, but you also have humans circulating in these areas, your reception area, your business office, your restroom, and so forth. Those are large particles, spatter. They're greater than 50 microns usually. Then we have droplets, which are smaller. They're less than 50. And then we have ultrafine particles in the realm of droplet nuclei. And the droplets and the droplet nuclei can float around in your practices because they're light in mass. Droplet nuclei are very concerning because they're less than 5 microns, first of all, but they're evaporated droplets. So they're very condensed, concentrated, pathogenic material that can embed very deeply in your respiratory tract. So the smaller the particle size, the more deeply preferentially they can infect you, and at the level of the alveoli, so inhaling those. And again, those droplets don't just stay in the operatory. They can travel all down your hallway. If you have patients or anybody using your restroom, flushing the toilet is a great source of aerosol as well. And that aerosol is highly pathogenic from a toilet, as you can imagine. It includes norovirus, it includes Clostridium difficile spores, it includes SARS-CoV-2. All right, measles, for example, has occurred when children who visited their physician with active measles left, other children walked into the pediatrician's office and became infected because those viral particles were still suspended in the air. So how long can airborne pathogens remain suspended in the air? For hours if they're light enough. Yep. Or I'm sorry, small enough. Light in mass. Would negative ion air purifiers bring down these ultrafine droplets? So their aerosol is really three-pronged. You have to have source control to begin with. And we'll hear Dr. Arguello talk today exactly that. If we can address the source, we can address 99% of this, but we still have to be concerned about the other 0.1% that's out there, or 0.1%. So what do we do? Again, we have to address it in zones. So the source control, we need ventilation. You have to have some way to ventilate and bring in outside air, and then filtration. And your filtration is important because you need filters that are going to filter out those very small particles. And you do that through HVAC and so forth. And we'll talk about that in a little bit more. So again, it's a little bit more complicated than you would think. All right, so indirect transmission again, vehicles, fomites, inanimate objects, dental instruments in our cases. But it can also be food if you ever had food poisoning, etc. And of course, blood and saliva. Housekeeping and clinical surfaces in a dental practice can be vehicles. And then vectors would be insects and so forth, which we're not going to be too concerned about. The portal of entry, this is how that pathogen enters a susceptible host. And that susceptible host, that area, must give supportive tissue so that that pathogen can continue to proliferate, to multiply and produce toxins. And routes of transmission, we said, oftentimes these pathogens will use the same portal to enter a new host as it did to exit the source host. We spoke about the fecal-oral route. The fecal-oral route is still problematic in dental practices because of cross-contamination. And of course, blood. And the host. So this is the final link in the chain of infection. Okay. And we have to be concerned about our patients. Susceptibility to illness depends on a few factors: their genetics, their current health status, their nutritional status. If you have a patient who suffered from xerostomia for a long period of time, lost a lot of their dentition, they're walking in to your practice with root tips, we have to be concerned, how is that patient going to heal, first of all? Are they able to fight off infection post-operatively, right? These are all things we need to think about. Specific immunity refers to protective antibodies. So maybe we were ill before and we have some antibodies, antigen, that we can fight off infection, again, from the same pathogen. Sometimes we don't. It depends on the type of virus and the bacteria. As we see SARS-CoV-2, not so much, right? We can still become infected. May not get as sick, but we can still become infected. So vaccine would be part of that specific immunity. Non-specific factors that defend us against infection would be our skin, our mucous membranes, gastric acidity. Your stomach has gastric acid for a reason, not just for digestion, but also to sterilize the food we eat and hopefully destroy any pathogens we might consume. Cilia in the respiratory tract, so we can move mucus, also our cough reflex, and then what we call the non-specific immune response. And I want you to hear very closely because this is important when we talk about infection control. Your patient has non-specific immune response. It's called their colon, right? It's called their gut microbiota. So when we prescribe antibiotics, we disrupt that nonspecific immune response. We disrupt colonization resistance. And now the patient doesn't have the ability to fight off the pathogens. So if they come into contact with Clostridium difficile contamination, whether it's in your practice or anywhere else, they have lost the ability in many cases to fight off infection. They ingest the bacteria, the spore, it converts to its vegetative form, it hits the colon, and it starts producing toxins. And that's how the majority of your patients get C. difficile. Now, the problem is that that antibiotic can affect them for up to 3 months after they finished it. So they can get C. difficile up to 3 months afterwards, after they completed the antibiotic. All right, so antibiotics can disrupt colonization resistance, and that increases susceptibility to Clostridium difficile infection in the presence of contamination or in the presence of an actual carrier. So as we close on the chain of infection here, the reason why we're here today is we're going to learn how do we disrupt the chain of infection and interventions that we can use to disrupt the chain of infection, right? So we can try to eliminate the source of the transmission. We do that through our administrative controls, which you all are experts at. What were your administrative controls with SARS-CoV-2? You'd have the patient wait out in their car. They text you when they came in. You had them fill out a questionnaire asking them if they traveled, did they have COVID, had they been around anybody that had COVID. You took their temperature. Again, if they're a carrier, temperature isn't going to tell us much. But these are all your administrative controls that we have to have in place so that we can prevent problems from ever walking in the door. Now, again, that doesn't apply to all carriers, right? Our infection control, which is why we're here today, antimicrobials. So if somebody has some sort of pathology and they're treated to clear that pathology, they're not going to transmit it to somebody else. Protecting our portals of entry through PPE, for instance, increasing the host defense, nutrition. So your patients that come in, they're partially edentulous and now they want their implants. We've got to get their nutritional status bumped up, right? Vaccination and probiotics, which are considered controversial. So again, we just reviewed intervention here, eliminating the pathogen at the source of transmission, interrupting direct transmission, isolating someone. Vehicle-borne transmission, we're going to what? Perform decontamination. So sterilization, disinfecting our surfaces and so forth, hand washing to prevent fecal to oral transmission, airborne diseases, modifying ventilation, air pressure, filtering and treating the air, and then vector-borne. And then intervention, protecting the portals of entry. We do that with PPE. We'll talk about that after our break. And then, of course, vaccinations to promote the development of specific antibodies to protect against infection. Doesn't mean that we cannot transmit that infection to someone else, because there are plenty of vaccinated patients walking around that still can harbor that vaccine or bacteria, etc., in their nasal cavity or the oropharyngeal complex. One of those that we need to be worried about, which is not vaccine related, but is MRSA. You have patients walking around that their nasal passages are colonized with methicillin-resistant Staph aureus. We now have hospitals and medical centers that are performing surgeries, including outpatient and inpatient, having their patients treat their nasal passages for a week prior with various substances to help eliminate MRSA carriers. And that's called nasal decolonization. Julie, I don't know. It would be dependent on your broadband connection. I would say if you're not using Chrome browser, use Chrome, but we're not experiencing any issues. So if you're on your phone, You can try it, but yeah, we're not having any issues right now. Would special extra infection control precautions be taken in a pediatric dentistry office? Well, we're going to talk about standard precautions and universal precautions, right? So, and we're on that slide right now. So that was good timing on your part, Dana. So in terms of pediatric practice, when we talk about universal precautions, we're talking about treating every patient as potentially infectious. We don't let our guard down. We don't look at a patient and decide they don't look sick. And many of these recommendations came from the time that I was training in dental school, because in San Francisco, we had many, many, many ill people walking on the streets. They had HIV and AIDS, many cases. They had Kaposi sarcoma. They were dying, and they were very thin from wasting syndrome. And, they looked like they had the plague often. And so many of these patients weren't able to get their health care because doctors were afraid, and they didn't want, at that time, we didn't know what caused AIDS, right? So because of that, because of discrimination, and just because of safety factors, the rule here is treat every patient walking through your door as a carrier of something. And then you can't go wrong, right? If you start applying different rules to different patients based on how they look or how they might have answered something on their health history, that's when you get into trouble. And we're going to see a video after the break of a dentist in Oklahoma that did the exact same thing. He was in an area with patients that had HIV, higher rates of HIV, hepatitis B, hepatitis C. So some of his patients, and he was an oral surgeon, he would soak the instruments in bleach, which made them very corroded. And we'll talk about that after the break. But he placed 7,000 patients at risk. Okay, so we use universal precautions to helpfully eliminate that risk. And it originally applied to the transmission of bloodborne pathogens. What do we do to reduce blood exposure through preventive practice? Well, careful handling of sharps, using a rubber dam, hand washing, and then, of course, PPE. So Doris attended UC 74 to 78. I had Dr. Silverman. I love Dr. Silverman. I have a great story about him. I studied HIV under Dr. Gerberding, who ended up being the head of the CDC, and others. And Dr. Silverman, I had my rotation in oral medicine, and so oral cancer. And when my father had cancer, Dr. Silverman would call him and make recommendations. My father had horrible oral mucositis. I love Dr. Silverman. Okay, so in 1996, the term universal precautions were expanded beyond just bloodborne pathogens to standard precautions. And standard precautions included blood and other body fluids. So saliva as well. Elements of standard precautions were really no different. Hand washing, PPE, sterilization of patient care equipment, disinfection of environmental surfaces, and then, of course, injury prevention. Personnel elements of an infection control program, education and training, immunization, exposure prevention, post-exposure management, medical condition management, work-related illness and restrictions, and then health record maintenance. Okay. And we've had a few of you that have had Dr. Silverman. I saw him here probably 8 years ago, just a year or so before he passed, he lectured here at our conference at the Western Regional. This stuff can get a little dry, so I'm going to take you through it, but hopefully apply some practicality to it as well. So develop a written health program for dental healthcare personnel that includes policies, procedures, and guidelines for education and training, your immunization schedule, exposure prevention, post-exposure management, address medical conditions, work-related illness, associated work restrictions, of course, address your employees that may have contact dermatitis or latex hypersensitivity. How do you handle your records? They have to be confidential. And so my recommendation for all of you that have to keep your logs for your employees in terms of vaccines, licensure, and so forth. There is software out there that you can get for onboarding. And when you bring in an employee and your existing employees, enter that information for that employee. That would be, when they need to relicense, their vaccine schedule, so if they're due for something, so that you're automatically notified, because it's really difficult to keep track of it. And this way they get notification and you get notification. All right, so you can look for that. Some of your practice management software may have that already, but it keeps it confidential. So only someone of authority would have access to that information. And I bring it up because I was consulting for a dental hygiene program once, and they were out of space. Space is always an issue. And they were storing their student vaccine records and injuries in the Home Depot boxes in the operatories of the clinic, unlocked. Right? Not good, not a good strategy. So you have to have some way to have these confidentially and confidential and accessible to the people that need to see it. Of course, we need to have a referral arrangement with a qualified healthcare facility or professionals in case there is an injury. Provide education and training at initial employment when new tasks or procedures affect the employee's occupational exposure at a minimum annually. Education and training, or if we change the materials that we're using, or we add procedures or anything that can expose the patient to different or the employee to different occupational exposure or hazard, right? And that training should be specific to their skill set, literacy, language, etc. Immunization programs, whatever your philosophy is here, it should be a written policy. So if you are hiring anyone, that you know what your policy is as well. And exposure prevention and post-exposure management, comprehensive plan you need to have in place. Everyone should have a copy of it, how to report, counseling, treatment, medical follow-up. Tuberculous skin test should be a 2-step test. Again, that is something that if your health department recommends everybody has it once a year or twice a year, depending on where you're practicing, that information could be in your credentialing software, so that if somebody's due for a test, it comes up and nobody slips through the cracks. Any questions or comments? All right. Personnel health elements that include medical conditions, work-related illness, associated work restrictions. Again, we need written policies around work restriction and exclusion. How your employees will seek care if they do become injured. We cannot penalize them with loss of wages. There was a practice that we used to bonus our employees for not taking their sick time. So what were we doing? We were encouraging them to come to work sick, right? Not a good strategy right now. Latex sensitivity and allergy, it's a good idea to have that employee tested to understand better what that's about. Some allergies can be quite severe. They can be respiratory in nature. And we'll see it's a sensitivity to the rubber protein in the gloves. I know most of you are probably using nitrile now. I do. I have a sensitivity after using latex for many years. But some of us now are developing sensitivities to the nitrile gloves because there are compounds in the nitrile gloves that can cause an allergic reaction or a sensitivity reaction. Okay, maintenance of records, again, we want them to be confidential. We want them in a way that we can make them accessible when we need to have them accessible, and to make sure that only persons of authority have access to that information. Preventing transmission of bloodborne pathogens. Charlene, I'm going to hold on to your question until after our break when we're talking more about disinfection and C. diff. But the answer is yes. If a person gets C. difficile, they may have C. difficile as a carrier for life. So does that mean you can take an antibiotic? No, you cannot take an antibiotic without having medical intervention. So if I have to take an antibiotic for something in the future, I'm probably going to end up in an infusion center getting a monoclonal antibody and taking high-level antibiotics to try to prevent the toxin from being produced. So it's a big deal for you prescribers out there. You cannot prescribe antibiotics to your patients that have had C. difficile, and we'll talk about that later. Bloodborne viruses include hepatitis B, hepatitis C, and HIV, all transmissible in healthcare settings, can produce chronic infection, and are often carried by persons unaware of their infection. Potential routes here: patient to dental healthcare personnel to patient, and patient to patient. So this is how bloodborne pathogens are transmitted. And we spoke about direct contact. We spoke about indirect contact earlier, and of course, aerosol. Factors that influence occupational risk of bloodborne virus infections: frequency of infection among the patient, risk of transmission after blood exposure, and type and frequency of blood contact. So I'll give you an example. I had a needle stick my third year. So my first year in the clinic at UCSF, my rotation was at San Francisco General Hospital. I had a patient with AIDS. I had a needle stick. He jerked his head back. I injected my index finger. Not very deep, but enough that it was a problem. And in 1992, 93, 92, we knew what caused AIDS, but we didn't know what the risk was if we had a needle stick like that. We do now because of all the dental students that got stuck. But in my case, if you look at this and you apply this, the frequency of infection among our patients was quite high. Many of our patients, at least 50% of my patients, had HIV and AIDS. Risk of transmission at that time, we knew it was through blood exposure, but we weren't sure what our specific risk was. But we knew it was a hollow stick needle. I was gloved. Was there blood on the device? Probably, because I was re-injecting. It was a root canal. And type and frequency of blood contact. So we're working in the oral cavity, which is vascular. All of those things we take into consideration. The average risk of a bloodborne virus transmission after a needle stick. So what this is doing is comparing the risk of transmission if we had a needle stick with a patient that was positive for hepatitis B, hepatitis C, and HIV. And what we're going to see is, of course, not all viruses are as robust, right? Not all lead as easily to infection. If we look at HIV, what we know now is that, and we didn't know in 1991 or 92, is that 1 in 300 needle sticks from an HIV-infected patient would result in infection. 1 in 300. Hepatitis B, on the other hand, 1 in 3 needle sticks, 30%, which is quite high. So hepatitis B, early on when I was a dental assistant before the hepatitis B virus or hepatitis B vaccine existed, and we weren't using PPE, by the way, no gloves. So bare hands and bloody mouths, no mask, no eye protection. We sterilized our handpieces with a 2x2 gauze and alcohol. What we know now is that vaccination of hepatitis B is very protective. Back then, where there was no protection, it could be a career ender for many dental clinicians and medical clinicians. Question here, how often do you need to get the hepatitis B vaccine? Hold on to that thought, and we'll address that here in just a second, Doris. So concentration of hepatitis B virus in body fluids, if we look at blood, serum, wound exudate, high, moderate in semen, vaginal fluid, and saliva, and in low to not detectable urine, feces, sweat, tears, and breast milk. If we look at the incidence of hepatitis B infection among healthcare personnel relative to the general population, and this was from 1985 to 1999. So 1985, I was a dental assistant, just starting undergrad again at Cal. If you look at 1985, look at the yellow line is healthcare personnel. Incidence was much greater than the general US population. But you see two blips here. You one at about 1987 and one at about 1989. You see another drop off. What happened there? Well, first of all, AIDS. AIDS, and we're going to see a very famous case around transmission of HIV from a dental practitioner, created a firestorm because it brought to light in dentistry that we weren't doing everything we needed to in terms of PPE and disinfection. And so we improved dramatically our infection control and implemented PPE. The second thing, at about 1987-88, vaccine, hepatitis B vaccine. So one of my professors at UCSF, his lab actually discovered the vaccine, but they didn't know it at the time. They found out later. Anyways, what happened is those two, that was the perfect storm to help bring these numbers way down below that of the general US population. So in 1990, they just lined us all up at UCSF, and we had to start getting our series of hepatitis B vaccines. So now the question from Doris here is, how often do you need to get the vaccine? There's no set number. What you need to do is check with your primary care doctor. So there's no set timeline. I can give you some examples. So my vaccine was, do the math, 30 years ago. I started attending UCS. So let's say actually 34 years ago. I was retested my titer about 10 years ago and I was fine. One of my classmates, though, retested 7 years after and she was not. So it depends on you. So talk to your primary care provider and let them know that you're in a high-risk population, you're a dentist, hygienist, assistant, how often, and just ask them to get your titer checked. Any other questions? All right, so hepatitis B infection among US dentists here, as we can see that early on, back in 1972, the pre-vaccine levels, 14%. 1989, those levels dropped dramatically. And then, of course, we have clinicians that have retired that may have become infected. And so the levels have been brought way, way below that of the general population. So we spoke about the vaccine. It's a 3-dose series, as you know. Once in a while, you'll have a non-responder. And in the case of non-responders, they don't respond to the vaccine. They will then be revaccinated. If they don't respond a second time, then they need to have a chat with themselves about their career choice. But Again, testing yourself later really depends on your physician and who you are and how often they think you should be tested. And you can just ask for a titer to be checked. Transmission of hepatitis B from infected dental healthcare personnel. So we see here 9 clusters of transmission from dentists and oral surgeons to patients. From 1970 to 1987, 8 dentists tested positive for hepatitis B, and lack of documented transmissions since 1987 reflect implementation of PPE in the vaccine. 1 case of patient-to-patient transmission in 2003. Hepatitis C virus, what we're going to see and what you're going to see on your quiz is that it is inefficiently transmitted by occupational exposure. 3 reports of transmission of blood splashed to the eye, and 3 reports of transmission from blood splash to the eye. Reports of simultaneous transmission of HIV and hepatitis C after non-intact skin exposure. So when I trained our patients that had HIV and HIV/AIDS, many of them also had concurrent other viral infections because why? Their immune system is not working on all cylinders, right? Immunocompromised. So if they had carried hepatitis C, it could reactivate. If they were a carrier of cytomegalovirus, it could reactivate. And some of them were IV drug users as well. So you had simultaneous infection going on. In the case of the needle stick that I had, that patient had HIV/AIDS, hepatitis C, hepatitis D, and cytomegalovirus. And the reason why I was stuck was the cytomegalovirus had caused him to have auditory hallucinations. So he would just laugh for no good reason and jerk his head back. And that's how I got stuck. Checking the questions here. Yeah, their class was vaccinated for Hep C. And does an air purifier in the room help with aerosols? We're going to talk about that, about aerosol in probably about 5 or 10 minutes. Okay, prevalence of hepatitis C infection, virus infection among dentists is similar to that of the general population. No reports of transmission of hepatitis C virus from an infected dental health care person to patients or from patient to patient. And there's been a risk of hepatitis C virus studied, and it's appeared to be low in terms of transmission. Doris said when they were learning to give their first intraoral shots as partners, she heard one student was so nervous, he injected his hand instead of his dental student partner. I believe it. Was that at UCSF, Doris? I can't remember if you said you were alumni. I want to remind you all to be sure you're using Chrome browser if you can. If you experience any audio issues, log out and log back in. Broadband doesn't always remain stable, as you know. So if you're on a class for an hour or two, sometimes you can experience that. Okay. HIV infection in dental settings. HIV was a game changer in terms of how we perform infection control now, and the safety elements that we have in our practices. We had to be retrained how to give injections. For instance, I was first trained to use my thumb and my finger and palpate anatomical landmarks, for instance, to inject for an IA block. Then the next year in the clinic, they said, nope, we don't want you to do it that way anymore, because this was right in the middle of the AIDS epidemic. We want you now to use a mouth mirror to palpate anatomical landmarks. We don't want you to put your fingers in there at all because they're worried about, of course, needle sticks. So HIV infection in dental settings. We have one documented case of HIV transmission from an infected dentist to a patient. No transmissions documented in the investigation of 63 HIV-infected dental healthcare personnel, including 33 dentists or dental students. This case, there's a lot of controversy around this case. I bring it up not because I want to talk about rumors or the controversy. This case launched a firestorm in the popular press because this was a dentist, Dr. David Acker from Florida, who had AIDS and allegedly infected 6 of his patients with HIV. And one of the patients, Kimberly Bergalis, a young woman, had extractions performed, developed AIDS, HIV and AIDS, and ended up dying. And her parents used her to attend, congressional hearings and so forth. I don't want to say use her, but used her case to talk about the importance of infection control and PPE and protecting the patient, as well as the fact that they wanted a law changed that would require every dentist to have to publicly post their HIV status. And I know in San Francisco at the time, and this case occurred while I was a dental student, and I know at the time there were many patients in San Francisco that were then very fearful of going to the dentist, and we didn't have enough information. So in our clinics, there were constantly things being added that we'd have to do to start our clinical session, making sure that we run the air water for 2 minutes. I think it was longer than that, and then they scaled it back to 2 minutes. Just a whole host of things, wearing gloves. Many of our clinicians, our professors, had never treated a patient wearing gloves before. So they were concerned that gloves would interfere with our ability, our tactile sense to perform dentistry. And when you think about it now, it sounds pretty silly, right? But these were all the things that happened primarily because of this case. And this was before the internet. So you can imagine what it would be like now, what would have happened. So yes, she attended congressional hearings. Parents wanted change. They wanted dentists to have to publicly expose their HIV status to the world. So it's considered the first documented HIV transmission from a healthcare worker to a patient in the United States, but the exact means of transmission was never known. And this was Kimberly Bergalis, and there's a YouTube link there if you want to learn more. 2 years after routine dental surgery, she developed AIDS. Her dentist is now dead, charged that he infected her. And this is what folks were seeing in the grocery line. And then they were afraid to go to the dentist. Okay, healthcare workers with documented and possible occupationally acquired HIV/AIDS. And you'll see 3 dentists, 1 oral surgeon, and 2 dental assistants under the possible, right? Claudia, you have to check with your own state. We can't. Now is probably not the time for us to be able to look that up for you. So we would require you to check on your own. Okay, risk factors for HIV after percutaneous exposure to HIV-infected blood. Deep injury, visible blood on the device, needle placed in an artery or vein, and terminal illness in the source patient. So for me, if we use my example, was it a deep injury? No. Was there visible blood on the device? Probably, because I was re-injecting, number 9. Needle placed in artery and vein? No. Terminal illness in the source patient? Yes. That patient, I think, had a CD4 count of 3. Characteristics of percutaneous injuries. Reported frequency among general dentists has declined because we've implemented various protocols, hopefully that they will continue to be declined. Often caused outside the patient's mouth with burrs, syringe needles, other sharps, involve small amounts of blood, and among oral surgeons occur more frequently during fracture reductions and procedures involving wire. Now, I can tell you that in the cases that I've looked at injury logs for various offices and so forth, and my own experience, it can also occur when somebody's decided that they have to change what they're doing. They may have been presented with a situation that just didn't fall in line with what they're normally, and so they make a decision, and it was the wrong decision, and they get stuck. That's number one. Number two, it's just somebody that decides they don't need to follow the rules. I can tell you when I was a dental assistant, we would bend the needle and screw it off the hub with our bare fingers, throw it in a milk carton, fill the milk carton up with plaster, throw it in the dumpster. That was our sharps control in 1981. So things have changed. Preventing exposure to blood and OPIM, we use standard precautions. We use sharps containers, and we establish engineering controls and work practices to prevent injuries. And then we develop our comprehensive program designed to minimize and manage exposure to blood and body fluids. So we're going to talk about engineering controls, work practice controls, and administrative controls. And you're going to see these questions on your quiz. What is an engineering control? It is isolating or removing a hazard. Right. An example would be sharps container or a medical device with some sort of protective feature on it. So self-sheathing scalpels would be an engineering control. Isolate or remove the hazard. Work practice controls, we change the manner of how we perform that task to minimize injury. So instead of injecting and using our fingers to retract tissue, we use some sort of metal retractor or the mouth mirror. One-handed needle recapping is another example of work practice controls. It's important that we identify, evaluate, and select devices that have engineered safety features at least annually as they become on the market or when we change a procedure or materials, right? So safe for anesthetic syringes, retractable scalpels, so forth. We use sharp containers. We do not recap used needles by using our hands or any other technique that involves directing the needle towards ourselves. We do not bend, break, or remove needles before disposal. Sounds like a given, but again, in 1981, that's exactly what we did. I'd bend the needle in half, boom. Then I'd unscrew it off the hub with my bare fingers. We don't do that anymore. They also had needle choppers. You can take it off and put it in a needle chopper and then throw that in the milk carton. Use either one-handed scoop technique or a mechanical device designed for holding the needle cap when recapping needles. Needle recappers are important. The metal heavyweight or paperweight style, I prefer. They have to be autoclaved. They're more pricey. The cardboard ones have become flimsy, and so I've seen some injuries with those, especially in our student cohorts. Policies, procedures, and enforcement measures. These are measures that you all are experts at now because COVID-19 had to make you an expert to be able to go back to work. You had to implement these policies, but they should be in place all the time, not to the degree, of course, that we had to during the early days of the pandemic, but they are placed in the hierarchy of other controls. So let me give you a case of a failure. I was working in a clinic as their pediatric dentist, and if I had a failed appointment, they would put an adult triage patient in my chair. And this time they put in a patient that was at the lab next door being tested for rabies because they were homeless and they were bit by a bat and they had hepatitis and another infection. And this person happened to see the dental clinic while they were at the lab and said, hey, why don't I just go to the dentist today? The patient didn't have an emergency, and were they someone that we wanted in the practice at that time? No, we didn't want them in the practice. They're coughing and so forth. So the administrative control failed. They should have been treated for all of the things they needed to be treated for and then returned to the practice. All right, post-exposure management program, clear policies and procedures, education of our dental healthcare personnel, providing rapid access to clinical care, post-exposure prophylaxis, and testing of the source patient, and follow the CDC recommendations after any sharp injury, mucous membrane exposure, non-intact skin exposure, or blood or OPIM. Wound management, exposure reporting, and assessment of infection risk all are required for post-exposure management. And now we're going to talk about aerosol. We'll talk about infection control precautions for oral surgery afterwards. Some use more laser in dentistry to reduce the need to use anesthesia. Yep. And develop anesthesia, as we see, there are some devices now that just make better sense. They're safer. They're more comfortable for the patient. So technology is getting there. Administrative control would also be to see less patients a day. Absolutely. So we were seeing and not having a reception area crammed full of patients too. That raises the respiration or raises the aerosol rate. I will be, Erica, we're going to touch on aerosols. I'm going to be talking, I talk about aerosol in much more detail during our 1-hour course too. So some lasers, you can actually, especially cold laser, you can pre-treat, precondition the area also. So photobiomodulation is an example, reduces the need for anesthesia, or it makes the anesthesia more comfortable and it lasts longer. Or using some hard tissue lasers in some procedures where you don't need anesthesia. Yes, so Sandra said her understanding is that staff should go to the occupational health care clinic immediately after the exposure, not waiting until the end of the day. Absolutely, and you have to have those protocols in place. So you have to have someone who is in charge of writing the report and making the referral. And that person needs to know, your employees need to know who that person is. In some states, yes, an RDH can use the laser. And if you go to the Academy of Laser Dentistry, they're a wonderful resource. We've worked with them for, gosh, the last 4 or 5 years. Go to the, it's called laserdentistry.org, Academy of Laser Dentistry, and they can provide you with training information. In Japan, they're using robots at the front desk with people at distant locations. Yep. Pretty soon they'll be using robots in the back 2 doors. Let's talk about aerosol management here and the importance. So this was the statement of the United States Occupational Safety and Health Administration that classified dentistry as one of the very high-risk occupations for transmission of the disease because of the aerosols produced. And we knew that before COVID-19. We knew that aerosol was an issue, and you're going to hear Dr. Aruelo talk about his experience and why he invented the aerosol assist, right? Because he noticed every Friday he felt like he had the flu. And he developed this device, and he was working on it before the pandemic. And then during the pandemic, he had some downtime to get it developed. So ultrasonic scalers, huge issue. Can transmit particulate aerosol up to 6 feet. Without an air current, can remain suspended from 35 minutes to several hours. So this was a study that looked at external high volume extraction. So again, we're talking about The patient zone, the operatory zone, and then the facility zone is what I like to call it. We want to address as much as we can in the patient zone. We still need to address the operatory and the facility, and that's why we have Dr. V on today. So intraoral is a device that he's going to show. It's sort of almost a hybrid between intraoral and extraoral. Then you've seen some of the extraoral, like the big vacuums that come in as well. Whatever you're using, you want to treat in the patient zone as much as you can, because it'll significantly reduce the aerosol particle counts in all sizes, significantly. All right, let me take a look at some of your questions here. So questions, Georgia dental hygienists cannot use lasers yet. Thank you. We're going to talk about pre-rinses after the break. So hang on to that. I will tell you, spoiler alert, the CDC believes that pre-rinsing has demonstrated efficacy in some studies, but the CDC believes it's an unresolved issue. Now, the studies definitely show that having patients rinse prior to a procedure is efficacious, but it depends on the type of rinse they're using. So at the beginning of the pandemic, what was recommended by the ADA? Hydrogen peroxide, which Health Canada banned because it's not effective. So take hydrogen peroxide off your list for a pre-procedural rinse. Has great other uses, but for pre-procedural rinse, take it off your list. Chlorhexidine gluconate, which is a poor antiviral. And then povidone iodine. Povidone iodine is excellent, but it stains. And there's some other issues with povidone iodine. What I recommend is take our course, Oral Rinses, What's Safe, What's Effective. Dr. Moskowitz goes through every antimicrobial known to man. Chlorine dioxide, acetylpyridinium chloride, povidone iodine, hydrogen peroxide, chlorhexidine gluconate, and then molecular iodine. And he is the creator of molecular iodine, so full disclosure. That course is an hour and a half, and it's available on demand. And he'll give the breakdown, the kill time. You know, for some of these antimicrobials to be effective, you'd have to rinse with them for 30 minutes. No patient's going to rinse with 30 minutes, right? In some cases, it might be 2 minutes. All right? So take the course, go to the website. Okay, great. Let's see if Dr. V's on here yet. He hasn't logged in yet. I'm going to go ahead now and put up their link so you can learn more. And we're going to play a video and then he'll log in here. If you have any more questions, please type them into the chat area. And let me go ahead and bring up the video. Some of you may not be able to hear this video. I will put the link in the chat area, and that has to do with your device. It's not anything we have control over because this program runs on a browser. If you have something in the background, like Zoom, it may conflict. Question here. What was the name of the rinse course again? It's called Oral Rinses, What's Safe, What's Effective. And it's available live. In fact, he's presenting, I think, next week or two, every month, and on demand. So the recording's there 24/7. So the best rinse, the rinse with the greatest efficacy is molecular iodine. Or sodium hypochlorite, bleach that's been diluted. If you've ever had to rinse with diluted bleach, your patients will hate you. I'll tell you that much. It's not pleasant. It's very effective, but it's not pleasant. So molecular iodine, and go ahead and take the course. But again, he gives all of the information. Molecular iodine was the only rinse that was found to be efficacious against SARS-CoV-2 in the presence of whole saliva, and that was tested by Dr. Christensen at Clinicians Report. Yeah. We're going to, Melissa, that's a good question. So we'll let Dr. V answer that question for you. All right, everyone, I'm going to play a video here. And again, this is the Aerosol Assist. This is not required for CE credit. It's a 30-minute break. I hope you'll stay on. This is a cost-effective device. It can be autoclaved. You can reuse it a few hundred times if you autoclave it properly. And they'll talk about that. And Dr. V is going to step back on and answer any questions that you might have. All right?
In this video, we will discuss how to use and maintain the Aerosol Assist. The Aerosol Assist increases safety and when used correctly increases work performance. We are confident that the Aerosol Assist will become a daily tool you come to depend on. The Aerosol Assist offers cost-effective aerosol suppression, intraoral fluid removal, and dynamic lip retraction in one easy-to-use, hands-free device. The best part is you do not need any specialized equipment or hoses to get started. If you have an HVE and a disposable saliva ejector, you are ready to go. We have received a lot of positive feedback and are thrilled that many top dental professionals and schools see the value of our product. It's your turn to reap the benefits. We have been fortunate enough to win several awards, including Hygiene Product of the Year. Practitioners can benefit from automating intraoral fluid and splatter control in a hands-free device. It also has integrated true backflow protection. It reduces chair time and improves practitioner ergonomics. Long-term exposure to aerosols is a health issue. This is comparable to not brushing your teeth on a regular basis. The first time you don't brush your teeth, it's not that big of a deal, but not brushing your teeth over long periods leads to oral health issues. Similarly, being exposed to aerosols on a long-term basis will start to cause long-term stress on your respiratory and immune system. Additionally, implementing different types of aerosol suppression devices can be taxing ergonomically on the dental practitioner. What is the solution? Our solution is the Aerosol Assist system, which is an ultra-lightweight, hands-free, autoclavable, extraoral system that removes intraoral fluids and provides high-performance aerosol suppression during procedures. The Aerosol Assist is designed to work in any office, but we have identified some challenges that your operatories might have when first learning how to use the Aerosol Assist. Making sure you understand the following concepts will make the learning process smoother. The saliva ejector. From falling off, being picked up by patients due to it being uncomfortable, or by it just doing its own thing after you find the optimal position, it is long overdue for an upgrade. The Aerosol Assist is designed to upgrade the functionality of a standard disposable saliva ejector so that it can be truly customizable, comfortable, and easy to use. The saliva ejector is one of the most used tools in dentistry, so why not make it as efficient as possible? Can any saliva ejector work with the Aerosol Assist? Yes, but we do have a favorite. We video reviewed multiple other brands of saliva ejectors for your benefit. The video explaining our criteria on saliva ejector rankings can be found on our setup page on our website. You can also download a PDF to see our favorites. We found that the right saliva ejector makes such a great difference that we started using them in our offices as it made our professional lives a lot easier and the patients enjoyed them as well. The Aerosol Assist is designed to fit a standard HVE connector. If the Aerosol Assist is not snug when you place it on the HVE, the O-ring is probably missing or needs to be replaced. Missing or damaged O-rings are common and cause the Aerosol Assist to not attach. Visually verify that the O-ring inside the HVE is intact to ensure you are ready to install the Aerosol Assist. The Aerosol Assist is designed to allow for easy rotation while remaining fixed on the HVE. We recommend positioning the aerosol cyst on a dental team member before using it on a patient to make sure positioning is correct and comfortable. When used properly, it should be very comfortable, and most patients will not even realize you are using a new device. When sitting the patient, it is important to have them in a supine position and make sure there is sufficient room to allow the HVE hose to fall in between the headrest and the chair. The HVE hose should be perpendicular to the floor and patient. Sitting them at a 45-degree angle can be done, but you need to make sure there is enough slack in the HVE line to not cause any additional tension in the line. It is not recommended to use the aerosol assist above a 45-degree position. The aerosol assist is a very simple device comprising of two channels. One is dedicated to removing intraoral fluids. The other is a 35mm aerosol port at the top, dedicated to removing aerosols and splatter during procedures. It is a hands-free device hanging onto the patient's lips via the curved buccal plate. It can also be used in conjunction with a bite block. The aerosol assist is designed to complement other infection control techniques and systems and works great with cheek retractors, rubber dams, bite blocks, ultrasonic scalers, high speeds, intraoral cameras, intraoral scanners, and lasers. What you see here is what we call aerosol visualization testing. The same setup is on the left and the right. You have the same lighting, the same scaler at the same setting. And what we're doing is we're benchmarking their success against the standard saliva ejector. Notice on the right as we move the scaler around the perimeter of the patient's mouth, little to no aerosols are accumulated, with the few getting pulled directly into the device. On the left, the patient has more splatter visible, and you can see the change of direction of those aerosols from the scaler as the patient breathes. This is something that is not easily visible to the naked eye with normal lighting. In this splatter visualization testing, we use a non-toxic fluorescent dye. It is run through the scaler, and then we flooded the operatory with black lights in order to more easily visualize where the aerosols are accumulating and to see if we were effectively doing a great job in reducing them. Notice the patient on the left and the accumulation of splatter on the patient's cheek, ear, neck, and hair. You can also see accumulation around the nasal passage, which will indicate inhalation of aerosols. When you compare that to the right, where we have the aerosol assist in place, you'll notice there's almost no accumulation of splatter on the patient's face, nor on the practitioner's hands and tools. The practitioner has both hands free to use their mirror as they've been used to, with little to no change in their workflow. The aerosol assist is a very versatile tool and can also take care of fumes generated by laser procedures. What you'll see in this video is a fibroma being removed. On the left, you have the aerosol assist, and on the right, you have no aerosol suppression implemented, only a saliva ejector. You'll see the drastic difference in the amount of fumes that are generated on the right versus the left. The aerosol assist is able to very quickly and effectively suck in these fumes, keeping the practitioner safe. Looking closely at the video, you see some of the plumes jet into the aerosol assist. These fumes are very toxic. There is a study in JAMA Dermatology which states that laser plumes have been shown to actually transmit diseases. The research states that strict care must be maintained by the laser practitioner to minimize potential health risks, especially when treating viral-induced lesions or patients with viral diseases. The aerosol assist allows the practitioner to use both hands. This allows them to focus on the procedure while automating intraoral fluid removal and aerosol suppression. After each use, the saliva ejector is discarded. The aerosol assist is then rinsed internally and externally to flush out any debris. The HVE port has two internal channels that can be cleaned with a standard brush. The aerosol port has access to those same channels and should be cleaned as well. After rinsing, they can be ultrasonically cleaned in an enzymatic bath and then placed in standard sterilization pouches. Load them single file on the autoclave tray and insert the tray in the top slot only. It's important to not place any other instruments or trays on top, as this may warp the device. Do not wipe it down with alcohol cavity wipes, nor dry it in an instrument dryer prior to placing it in the autoclave. The aerosol assist demo units do not come with a warranty. However, a full kit comes with a 6-month manufacturer warranty. If the aerosol assist cracks or deforms within 6 months of purchasing, please contact the aerosol assist team via email with proof of purchase for a replacement. The aerosol assist is able to treat patients with limited ability to open, TMJ issues, pharyngeal or gag reflex, and is the go-to choice for prophylaxis, SRPs, anterior restorations, crown cementations, endodontic procedures, procedures that use a rubber dam, implant placement, and second-stage surgeries and extractions. At around 30 cents a use, it is the most affordable option because of its reusability. You will benefit from the aerosol assist from the first time you try it. However, we recommend using it multiple times with different procedures to have a better understanding of how it works in different scenarios. It is a tool that can be learned easily, and once you see its benefit, you will want to have it in your armamentarium. The aerosol cyst is the only system to simultaneously remove aerosols and intraoral fluid removal in one hands-free device.
Okay, everyone, I'm going to go ahead and introduce Dr. V to you. I see he's here. There he is. Hey, Dr. V.
Hey, how's it going?
It's going very well, thank you. I'd like to introduce everyone to you. And if you hear an exceptionally whiny little dog in the background, she's on a timeout. So sorry about that. The farmer's dog was delivered and she smells it. If you want to be honest here, that's what's going on. All right, everyone, I want to tell you how happy we are to have Dr. V here today. Dr. Abuelo is a dentist, inventor, and entrepreneur, and coming from a family with strong roots in medicine, he naturally gravitated towards this industry. He graduated from Florida International University, majoring in chemistry, and then Boston University Henry M. Goldman School of Dental Medicine. He is the co-founder of Pivatool and the inventor of the patented Aerosol Assist, an innovative aerosol reduction and intraoral fluid removal device. His ultimate goal is to revolutionize dentistry by giving practitioners and patients the skills to eradicate dental anxiety, fears, trauma, and any other negative habit that limits the human condition. He currently practices in one of his practices in South Florida, and he enjoys multiple aspects ranging from treating patients, photography, psychotherapies, and product development. We have his psychotherapy course on demand on our website too as well. So thank you for being here, Dr. V. We have questions for you already. And go ahead and type your questions in the chat area. And I want to remind everyone too, at the top of the screen, you will see the banner to reach Aerosol Assist. And Dr. V, I don't know if there's any promotion or anything going on.
Yes, the promotion is Dent, DENTCEMAR, so Dent CE March. And it's 20% off. And also anybody who does purchase today does get buy one, get one. So that's for the purchases done today. And
okay.
For anybody who has to go ahead and take it to their office to show everybody to see if they're going to go ahead and get it, they still get 20% off by using that code. So
that's an awesome deal, everyone. You better take advantage of that. I've got Brandy here saying, hey, Dr. V.
Yeah, Brandy's the best. We worked with her for a good amount of time. So I love seeing people we've met for a very long time. And she's used the Aerosol Assist. She likes it a lot. She was a big cheerleader, especially in the beginning. So I really am happy to always run into her at different events. In terms of the the black lighting, I saw that somebody said that they liked it. That was really cool too when we actually did it for the first time. The first time we actually did that video, since we didn't know exactly how fantastic it was going to look, we had to go ahead and mute it because all you heard is expletives like, oh my gosh, I can't believe how great that worked.
That's funny.
Mm-hmm.
There's go ahead. No, because it is. I mean, it's so dramatic when you see it, and it just, you forget working day to day, and you don't see it. And when we don't see something, we forget it's there, or in our mind we wish it was gone, right? So it's good to see it that way.
Absolutely, absolutely. Like it always takes something to go ahead, and it's usually something negative to go ahead and make you start implementing things. Like for example, one of the biggest mistakes I ever made was not having my patients wear glasses. And then one day, something flew out. I think it was a piece of acrylic, got into his eye and he got a bad infection. I was like, I'm never going to let this happen again. I know you always should. And for some reason, I just wasn't doing it at that point. That was luckily an early mistake I made very on. And I never made it again. So now all my patients wear glasses, which is something obviously you're supposed to go ahead and do. And the same thing happened with aerosols, where for a long time, I just was working without any single problem. And then I started noticing a pattern of, I just started getting sick, and not horrifically, but just, an itch at the back of my throat. And I realized, this is obviously coming from the work environment. And the only reason I even figured that out was because I started using aerosol reduction devices, not necessarily mine, because mine wasn't invented at the time, but like, for example, isolation devices. And then once I saw how great I felt, I started implementing aerosol reduction devices for every single procedure, not just the ones that I'm personally doing, but the one I wanted it to be done in my office. Even if other practitioners are going to go ahead and do their work, they had to go ahead and have some form of safety for that reason.
There are a couple of questions about how and where they can find the promo link. So at the top of the screen, there's an orange banner. And if you look at the button, there's the promo code. And I'll also put the link in the chat area for you as well.
Yeah, and then everybody will also receive an email with instructions too. So.
Okay.
Absolutely.
All right. I've got the link there for you too. Okay, we have more questions coming in here. So Brandy makes a comment there for you. And there was a question about patient comfort, and I think she came in and did an amazing job as well. But some of the patients, I guess, in this practice may have experienced it wasn't settled right or something. Is there something you want to say about that?
Absolutely. Yeah. It's a tool, so you have to go ahead and see how to use it correctly. For example, I see a lot of people, if they have the old aseptic hoses, all they have to do to make it a lot more comfortable is making sure that the hose is able to go ahead and get a lot more friction with the chair itself. So one thing is to make sure that the headrest and the chair have enough of a gap to allow the hose to go through. If you have the newer corrugated hoses, I think the best thing to do is lay them down completely supine. And then obviously if you have those those older hoses that are a little bit heavier, you're probably going to want to angle them up a little bit between 0 and 45 degrees so that the chair itself, the friction from the hose interacting with the chair is going to go ahead and add a lot of support. And that works really well. Actually, that works so well that if the patient moves, the friction actually stops the the aerosol cyst from actually following the patient. So that could be probably the only hindrance where it works too well. There's always a solution. You just have to go ahead and find it. We have lots of videos explaining in different situations what you could go ahead and do to make it a much more comfortable experience. My recommendation is always trying out the aerosol cyst on each other first. That way you're able to see, okay, well, what are its limitations? And again, the limitations are just always have to be figured out. But once you figure out how to use it, it is one of these things that there's always going to be a solution for whatever problem. And then it just becomes very easy to use. Very easy to use.
I know when I first started in dental school, the complaint was having to wear gloves. Okay, so we've come a long way. People complain, do I have to really wear gloves? Yeah, you have to wear gloves to treat patients in the clinic now.
Yeah, and I can understand because there's no device like this. The idea is that we wanted to go ahead and make it so that it doesn't need a bite block, because usually a bite block is something that would stabilize the device. You could still use a bite block with our device, so that's not an issue. They have these really cheap bite blocks that you can go ahead and buy on Amazon that have a channel that goes between the maxillary and the mandibular, where the saliva ejector is able to go ahead and go through. And that's really fantastic because it's a very economical addition to the aerosol cyst that isn't necessarily from us. So if you wanted that extra stability, you could use that. But the idea is not to use one, because a lot of the patients complain about that. Having to stay in a very static position for a very long time is annoying for most people.
Right.
And we figured if we could make a device that doesn't necessarily need that, that's going to be a lot more comfortable for the patients. And so far, especially because we've done we've tested it and tested it and tested and tested and tested it. We know exactly what to go ahead and do to make sure it's comfortable for every single person.
Okay, great. And I want to remind everybody that the top of the screen, if you go to the banner, you can bookmark that as well and save it to your device and take the information back to your practice. And we're recording this today, so you can share the recording with your practices as well. And then Aerosol Assist will send you an email with all of the information. Any other questions? And Dr. V, I believe your website also has quite a few instructional videos for different things, correct? So
yeah, absolutely. And we're still going to have a lot more. Like, for example, one of the ones that we're going to do is if you wanted to go ahead and get the aerosol cyst out of the way without, well, we'll show those videos. I'm not going to try to explain it right now. But yeah,
right.
we're going to put up a lot more because, again, since this device is relatively new, we're still figuring things out. We originally made it so that it's more of a for hygiene, and then I started using it myself for pretty much every single procedure. And the biggest reason is just because a lot of the patients couldn't necessarily tolerate all the other devices. So now I'm using it pretty much for like 70% of my patients. It's not to go ahead and say it's going to replace everything, because any single time I could go ahead and use, for example, an isolation device is still fantastic. It's a tool. So it's the right tool for the right job. So if it's going to help me out, I'm going to use it. If there's something else that's going to be better, I'm going to use that too. But again, it's just coincidentally that 70% of the procedures, I have to go ahead and favor this.
Okay. Any other questions, comments? Brandy has added quite a bit to this morning's
thank you so much,
presentation. That's great. Yeah, she said here that she purchased hers on her own because her doctor bought a huge extra oral machine. She said it was the best money she ever spent to this day. She's not contracted COVID, even though everyone else in her office has. So COVID, unfortunately, has not gone away. It just sort of reminds us sort of it's still here. And my son was supposed to come over and visit next week and called me and said, Mom, I have a cold. And I said, good, well, you stay where you're at. And when you test negative, you can come back. But for now, I really don't want you here. Okay, so Brandy has information about setting up the patient correctly in the beginning of the appointment. Then the rest of the appointment is a breeze. Make sure the patient is all the way up on the headrest so the cord lays correctly. The more you use it, the easier it gets. And I would imagine that the cord, like you said, has a lot to do with it. If you have a heavy cord, you're going to get some drag.
Yeah. And actually, one of the things that we're working on is creating a cord. We really wanted to go ahead and make it so that you didn't have to buy an extra cord. But since there are so many different kinds of, I guess, not just in terms of how heavy the cords could be, they vary wildly. Like some of them are very, very heavy. Some of them are super light. And every single, but also the configuration of where they actually get inputted into the chair. I remembered there was this one client that messaged us and saying that it wasn't the heaviness. It was just that their cords actually come out from a 90 degree from the chair.
Right.
And that 90 degree angulation causes it to like really start to bend. So because there's so many variations, what we're going to do is we're going to create our own cord that's a lot easier to go ahead.
Oh, that's a good idea.
Yeah.
Yeah. Yeah.
So that's coming.
That's great. Question from an assistant. How does the assistant suction while using the aerosol assist?
Oh, that's a really good question. One of the things that we love using the aerosol assist for is for when the assistant actually has to go ahead and use it. We actually recommend that they use the aerosol assist in one of their hands, their non-dominant hand. That way, now you'd have to position the saliva ejector in a slightly different way. And the reason for that is because that way you could still use the aerosol assist as a retraction device too. And so you could use it as a retraction device. You could use it to remove all the intraoral fluids and obviously all the splatter and aerosols that are coming out. So it's a 3-in-1 device that you could go ahead and use in one hand.
Great.
So, and if for whatever reason they have to go ahead and leave, they can just let go of it and it's pretty much going to be the same.
Another good point too, and they're all good points, but the fact that it has a built-in retraction device, if you are treating children and they do want to suck on that saliva ejector, it's protective. So
yeah, absolutely.
Or you have that one strange patient that likes to do that. That's
that seems to be a lot of my patients.
Brandy said she loves it for sealants. I would imagine it's great for sealants. I wish we would have had it here at the county, because we had one of the largest sealant programs in the U.S. and that was a real issue with controlling moisture and isolation, not isolation, but patient. We didn't have assistance, moisture, and then we had to go back in and randomly check 4 or 5 cases the next week. And this would have eliminated all of that. It would have been a real cost saver for the county here. If anybody here is from Maricopa County, that was a commercial for you all to call Dr. V. All right, any other questions or comments? And again, if you tap on the banner at the top of the screen, bookmark that link, you can take it back to your practices and you'll get an email later. Thank you, Dr. V, for being here today. Have a good weekend. All right, bye now. All right, everyone, we have a couple of minutes here before we start back up on part 2. And if you want more information about the Aerosol Assist, just tap on that banner at the top of the screen. Okay, so we'll be starting here in just a couple of minutes. And if you have any questions from earlier, please go ahead and type them into the chat area. Okay, we'll be starting up here in just a couple of minutes. And the handout is back up on the banner if you need that. I'll also repost the link here. For those of you that need the link to Aerosol Assist in the promo code, I'm going to post it because it's buy one, get one, which is a great offer. And you'll be receiving an email from them as well. Okay, just one more minute. Make sure you have the handout. Good, I'm glad. Thank you. Great feedback. Thank you so much. We're going to get into the real nitty-gritty now. This is the first half is a lot of the administrative stuff that can be sort of boring, but I try to give you some history behind it. But now we're going to get into the to the exciting stuff here. So let's go ahead and get started. And we're going to talk about this half: PPE, hand hygiene, sterilization, autoclave monitoring, post evaluation, and so forth. So I'm going to start by showing a video on contamination in the dental practice and Clostridium difficile. And it's a very good and hair-raising tale that you hear here. But the reason is that our infection control in our dental practices is so important. And my concern here is for those of you that are much younger than me that didn't live through the HIV/AIDS period or learned how to train through that period when it was really high risk and so forth. You may not have been exposed to the fact of just how life-threatening a situation can be. So I was infected with Clostridium difficile in February of 2022, 2 years ago. It followed a simple extraction of number 3 and an antibiotic, clindamycin, that was prescribed just in case as a defense prescription. There was no infection present. This was an endo-treated tooth that I fractured down the middle from heavy clenching. And I decided I wanted an implant. The decision was to extract that tooth, socket graft, LPRF, and have me back a few months later to evaluate for an implant. And the procedure went fine. I went back for a post-operative check a few times. And when I went back for the 30-day check, he said, everything looks great. No more soft diet. We'll see you here in March. And so that was mid-February. 2 days after that visit, I became terribly ill. There was something terribly wrong. I was bleeding. I had no idea what was going on. And I made an appointment with a gastroenterologist. They could not get me in for about 9 days because of COVID. And I ended up being diagnosed with C. difficile, and I had been misdiagnosed a couple times. Mind you, this was a full 30 days after I had finished the antibiotic, and it was 48 hours after being in the dental practice. So it raises the level of concern. Was I a carrier, or did I become exposed to contamination when I returned to that 30-day checkup appointment? We'll never know. But you'll see from this video, and this is by Contagion Live, these are 6 experts on infectious diseases, on Clostridium difficile. Some of them are gastroenterologists and so forth. And they're going to talk about contamination. They're going to talk about the perfect storm for your patient getting Clostridium difficile under your care. And they are going to call out dental practices as well. So let me go ahead and play that video for you. In the video, I'll put the link in the chat area as well. And I believe it's in your handout. And again, if you have any questions in the meantime, please let me know by typing in the chat area. And of note, what I want you to hear them say is, or what I want you to hear in this is that contamination doesn't stay in the dental practice. It follows you home. It follows you into your vehicle. It follows you to the preschool that you may be picking up your child. So that's why we have to be really, really careful. And it's not fear-mongering. If we put simple things in place, which we should have already, that should protect us. But when we let down our guard, if we have an employer tell us, well, you don't need to really do that, and you know you do, that puts you at risk. And it puts your family at risk at home.
So let's talk about community C. diff, if we could, for a moment. What are the risk factors in the community, and how do they differ in the community versus the hospital-based population here? Dale, you want to start us on that?
Yeah, that's a really good question, because there's 2 factors that we need to have in order to get C. diff. One is antibiotic use, and the other is exposure to the spores. So the spores are ubiquitous. They're out in the environment. They even contaminate at a very low level some foods, meats, root vegetables, lettuce, and those are probably how patients in the community get exposed. They, on the other hand, when the CDC has looked at community-associated C. diff, they found that about 80% of these patients have had an exposure to healthcare as an outpatient. So it's doctor's office, dental office, and chronic dialysis units, ambulatory surgery. And this is where you have two risks. One is that somebody's going to give you an antibiotic, and those are called doctors. And
We hope it's only doctors.
They put people at risk of C. diff. And the other exposure is that the healthcare environment is more contaminated with C. diff spores than is the environment outside of healthcare.
And I think it's worth noting, Paul is nodding his head. He has a lot of nodding. It's not just the people who are in the healthcare system. It's not just the people who got the antibiotics. They go home. They've got spores, and then their families are exposed. So it seems to me that that's part of the issue, isn't it?
And those spores can live for a significant period of time on many different surfaces, even when exposed to sunlight. And you'll see some data that says alcohol and certain products can kill the spores, but that it really has to be used properly, where the liquid sits on a surface for a significant period of time to have its effects. So the fact that the spores can be taken home with you on your lab coat and in your house and on surfaces for 6 months or a year or longer certainly put people at risk.
Okay, so here's the problem in dentistry right now. We prescribe antibiotics. We have an environment that's contaminated with C. difficile spores. We're not immune. We're no different than a medical practice or anywhere else. We invite our patients back for post-operative check, root canal extraction, what have you, and we put them at risk for developing C. difficile. The problem that we have is that we're not using disinfectants that kill C. difficile spores. And having survived a life-threatening illness and the fact that you all aren't being taught this, I'm now a national speaker. I want to make sure that everybody knows that this risk is real. All right. Also, if you're taking an antibiotic, again, for a sinus infection or UTI or whatever, it puts you at risk as an occupational exposure. So there are medical facilities now that will warn their employees of that. If you're taking an antibiotic while you're working in this facility, wash your hands. You are at risk for C. difficile. And every time I present these courses, there are going to be a handful of you that reach out. They'll say, yep, I got C. difficile. I had a sinus infection. I have other dental clinicians that also got C. difficile after a dental procedure and taking antibiotics as well. And I want to stress again that the actual carriers in the general population are relatively low. But the community-associated infections, and you just heard the experts speak, those cases are going up. And half these cases are antibiotic resistant. You don't have a cure, you die. Right. So I want to make sure that you understand the safety level here, how serious this is. We're going to start with hands here. And I had a couple of questions. Should we start asking patients on health history forms if they've had C. diff? Absolutely. And again, take my C. difficile course. We also have an update on antibiotics coming up in June the 7th, I believe. Dr. Tom Palmeyer from the American Dental Association is the co-author of the guidelines. And for you prescribers out there that are still prescribing clindamycin to your penallergic patients for antibiotic prophylaxis, need to update your prescribing practices, because clindamycin was removed from the guidelines twice over the last 6 or 7 years. So you're putting your patients at risk. That's enough on C. difficile. And let's go ahead and continue on here. Prophylactic antibiotics all antibiotics raise the risk for C. difficile, all antibiotics. So we want to make darn sure the patient needs the antibiotic. That is called antibiotic stewardship. About 80% of us, clinicians, dentists, do not practice within the guidelines for the antibiotic prophylaxis. We're overprescribing. It puts you at risk too, because the American Dental Association removed clindamycin from the guidelines because of the boxed warning and the number of dentists that are getting sued because of C. difficile infections in their patients. So let's start with hands. Hands, as we said, when we're talking about the mode of transmission, hands are the number one mode of transmission of pathogenic of infection in our dental practices. So effective hand hygiene is essential to reduce the spread of antimicrobial resistance. You are not resistant to a particular bacteria. Your bacteria becomes a mutant, It mutates. Bacteria rapidly divide, rapidly reproduce. Right? So do viruses. In the case of bacteria, if you come into contact with a bacteria that's developed a resistance, let's say, to an antibiotic, like in the case of the C. difficile infection I had, you don't have a treatment, you die. There's no treatment. You don't have antibodies against C. difficile, toxin B. You die. So I had to have a life-saving measure to save my life, called a fecal transplant. And that's reserved for life-threatening cases. Also prevent healthcare-associated infections. I often think, in dentistry, we aren't fined if somebody gets sick because they set foot in a contaminated dental practice. It's difficult to track, although there are now more tracking mechanisms that are going to occur. But in a hospital, if somebody's in that hospital and they get a C. diff infection or MRSA or whatever, it extends their hospital stay. It may even kill them. The hospital is going to get fined. The hospital has to pick up the tab for treatment. My bill was $83,000 to treat that C. diff infection. If that bill had gone to the clinician, things would change very rapidly in dentistry, right? And things are going to change. Things are going to change because we have the technology now to trace these prescriptions. And if the pharmacy now can see you prescribe clindamycin for antibiotic prophylaxis and the patient comes back to that pharmacy for difficid, which is diagnostic, it's an antibiotic for C. diff, there you go, right? Now we know we can trace the infection. Prior to that, we didn't have a way to trace it. Yep, so hand washing is number one here. So there are two microbes of the hands, resident and transient. The resident microbes are the normal microflora that would be on your hands day to day. There's some overlap with the rest of humanity here. We see the overlap of about the same types of microflora, right? Now on our hands, when we shovel snow or we're, whatever the case may be, where we're using the hands, we build up calluses. That's the stratum corneum, and those microflora can then get embedded in the hands. So we have to scrub when we're performing a surgical scrub, to try to remove as much as possible. We're not going to remove 100%, but we want to bring the levels way down. Because when we wear gloves, those gloves are dark, damp environment that increase the proliferation of whatever remains on your hands. So when you take your gloves off, your hands are contaminated. So if you take your gloves off and you reach for your phone or you go to a keyboard without washing your hands, that is cross-contamination. Transient microflora, those are the hitchhikers. Those are the ones that we pick up from contaminated surfaces, patient contact. Our cell phones are a huge risk factor for contamination and so forth. So these hitchhikers are concerning because they potentially contain any form of disease-causing agent that the patient walks through our door with. The concept of hand washing and surgical scrubbing is to reduce the amount of resident microbes present. In order to do that, antimicrobial soap should be used in the case of surgical procedures, or plain soap and water followed by a surgical gel lotion with persistent activity, as we'll see. We perform hand hygiene on our day-to-day procedures in our practice with either a non-antimicrobial or antimicrobial soap and water when hands are visibly dirty or contaminated with blood or OPIM. And if hands are not visibly soiled, we can use an alcohol-based hand rub, follow those manufacturer's instructions. So the CDC tells us that if the hands aren't visibly soiled, we can use a 70% alcohol, right? Here's the deal. The deal here, first of all, this is not sporicidal. Doesn't kill spores, all right? The alcohol-based hand sanitizer. But we know if we implement the use of such in healthcare settings, it significantly will increase hand hygiene. In hospitals, going from a bedside over to a sink, that's a deal breaker. Many nurses now aren't doing that. That's a problem. So alcohol-based hand sanitizer is important, and you have to use it correctly. So even though it's not killing spores, as my mother would have said, it's better than a poke in the eye with a sharp stick, or at least killing 99% of the germs. Ideally, if we can wash our hands under the sink, there's running water. If there are spores on our hands, they're going to get flushed away. Follow the manufacturer's instructions for the alcohol-based hand sanitizer. If you put it on your hands like a little lotion, put a little dab here, you do this, and you grab the gloves, and you know what I'm talking about, that's not going to do much for you. So you have to apply a sufficient amount to keep your hands wet for as long as the manufacturer states. If you need to use it for 10 seconds and your hands are dry in 2, you didn't apply enough, you didn't cover everywhere you need to cover on your hands, and you didn't use it long enough, right? So follow the manufacturer's instructions. Many operatories and dental practices now are being built out without sinks, which is kind of crazy. Okay, indications for hand hygiene. Hands are visibly soiled after we touch something with our bare hands that may be contaminated, before and after we treat every patient, before we put gloves on, and immediately after we remove our gloves. For oral surgical procedures, we perform surgical hand antisepsis before we put our gloves, sterile surgeon's gloves on. Follow the manufacturer's instructions by using either an antimicrobial soap and water, or soap and water followed by drying the hands thoroughly and applying an alcohol-based surgical hand scrub product with persistent activity. We want to keep the skin intact, and we have a question here. How do you deal with skin cracks from hand sanitizers and frequent washing? So in the evening times, I apply heavy-duty moisturizer and moisturizing gloves that I sleep in at night when I'm giving my hands a rest. If these skin cracks that you have are not healing, I would recommend you see a dermatologist and then look at the soaps that you're using, because it could be something in the soap, right? And definitely using products to maintain the skin. Now, some of these manufacturers are going to have to check with your gloves to see what's compatible with the glove as well, what emollient, what they suggest. So some people have very good results with a little aloe in their hand sanitizer. That's what I've used. Gina said it's shocking how many dental healthcare workers who do not wash their hands, restroom or operatory. And I'll tell you a quick story. Back in September of this year, I had to go to the hospital for vertigo, and they decided to keep me overnight. What ended up being nothing, really. I was a little dehydrated, but they kept me overnight for observation to do more tests. Not one nurse washed their hands. They would walk in the room, they'd want to flush out my IV line, and they would just grab 2 gloves after using their computer, everything. And I said, whoa, whoa, whoa. I said, if you look at my chart, I had C. difficile for a year. I'm not going to let anyone touch me without washing their hands. And they'd say, oh, okay, fine. Even though on the doors of every hospital room, it said before you enter this, or when you enter this room and upon leaving, you will wash your hands. None of them were doing it. And on their carts with their computer, they had a tub of Cava wipes that were dry. They call them purple tops, dried out. So you knew they hadn't used them, for years. That's a problem. Your patients look at you. They want to see you washing your hands. And if the dentists aren't washing their hands, the rest of the team's not going to wash their hands. So be proactive. If you go in and you look at Yelp reviews or Google reviews, look for the low reviews for dental practices and see what patients are posting. It's around the hygiene of not the sanitation of the practice. My dentist didn't wash their hands before they touched me. I won't go back. My dental assistant touched my instruments with their bare hands. I won't go back. And this is what they're posting online. So it's a safety issue for the patient. They want to know that you're doing everything possible to protect them. Is there a way to be 100%, infection control safe? Nothing in this world's 100%, Abby. But if you implement what you should and what you're supposed to implement, you are going to be far better off. So everything we spoke of today, if you implement, should protect you, right? And protect your patients. If you're being told to sanitize your disposable gown with Cava wipes and wear them for 3 days, that's a problem, right? Because leadership is trying to save money. That's what I've been told. And I get budgets. I had a $2 million budget here at the county, right? But there are some things that we have to be smart about. And infection control, we have to be smart about it. Any other questions? Okay, I think I got all of them. I will check back in with you. Pre-medication, what I would say is go to the American Dental Association's website and look at the latest guidelines because it's not black and white. Azithromycin is one option, but not all patients are candidate for azithromycin. What do you do when you're allergic to antimicrobial soap? So find out what it is in that antimicrobial soap that you're allergic to. If you're performing day-to-day dentistry, you don't necessarily need to use an antimicrobial soap, right? So as long as you're using soap and you're washing your hands sufficiently, but find out what it is in the ingredients. Dora said that's why statistically nurses get diseases, COVID, etc. I don't have the data in front of me, but I can tell you that statistically that's why their patients get sick. And that's why the hospitals get fined. And they're very worried about hands. Hospitals usually have a huge campaign about hands because, again, they know it's the #1 mode of transmission. All right, moving along here. Here's the areas that are commonly missed during hand washing: the back of the hand, fingertips, the thumb, the wrist. And I always kept a diagram like this above all of our sinks in our clinic as a reminder to my staff to wash their hands and wash them effectively. And so our patients could see that. We were demonstrating that this was important in our clinic. I'm going to show you a quick video here. This is called the purple paint video. And this video was done by a nurse to teach students. And it's very applicable to what we do. It's 20 seconds. If you memorize this thing, you're going to be golden because you'll have the ability to wash your hands effectively and make sure that you wash all the surfaces. So she's not washing her gloves on purpose. She just doesn't want to dye her hands purple.
Let's first put soap in the palm of our hands, and then begin to rub in between like so. But as you see, there is no soap on the back of my hands, so I'm going to interlace my fingers palm to palm, and then I'm going to do the same technique on the back of my hands with each hand. And then you're going to take the back of your fingers to opposing palms with fingers interlocked. And then start rubbing your thumbs. And then you're going to take your fingertips, clasp the fingertips in the right hand in the left palm, and vice versa. Rub your wrist one last time to make sure your hands have been completely covered in soap. Thanks for watching.
Okay, so that link is here in your handout. It's a great link to share if you teach dental assistants, dental hygiene, and so forth. It's a great link to share with your entire staff. And again, you just memorize that technique and you're good. Now, also address the nails. What I recommend is to buy just a box of round wood toothpicks, keep them in the operatories, clean under your nails at the beginning of the day, especially at least once, and maybe at the end of the day. Also, rings, jewelry, etc. should not be worn on your hands with gloves. The gloves tear, you get micro tears. You also really don't want your jewelry being exposed to these pathogens. How do you know that you've removed them all? Do you want MRSA hanging around on your beautiful engagement band? I don't think you do. So I would take them off. If you want to have them with you, get a nice chain with a catch and wear them around your neck. Acrylic nails, gel nails are absorbent, not recommended. If you're wearing nail polish, make sure that it's not chipped because it's absorbent. How many of you are using a soap dispenser that looks like this or like this? Go ahead and type yes in the chat area or no. And while that's being done, I've got two questions here we're going to take a look at. We were taught that patient gloves are always dirty, not surgical gloves. True. I do the reverse. Surgical gloves should be sterile. Right? Surgical gloves are sterile. So when we're performing surgery, they're sterile. Your day-to-day medical gloves that you purchase are not sterile. So I wouldn't say that they're dirty, but they're not sterile. All right. There's another hand washing video here that was posted by Doris. Thank you, Doris. Okay, so a lot of you, yes, we have a few of you know. Some are using automatic, good, non-refillable, throwaway. All right. Yep, short nails, no polish, and use a nail brush. That was the old days. Ketchup bottles at restaurants are not supposed to be refilled. This is correct. Hands-free automatic. Excellent. All right, so let's talk about these very quickly because we've got a lot to talk about. Bulk soap refillable dispensers are identified to have the most significant risk of microbial contamination. Biofilm grows in these. You can't wash them. You can't disinfect the inside. The biofilm comes right back. It has to do with this handle here, the pump, because pathogens get in that pump. They get into the system. And if you ever see these in a restaurant, take a look in there sometime. It's green, it's black, it's slimy, it's biofilm. But these are the same model. You can't, even if you're throwing them away after a week, this is really a problem and it's quite dangerous. And even though it's antibacterial soap, you still get biofilm. So the system you should really use, as we'll see, is touchless. Well, we said the hands are the most risk for transmission of infection, right? So let's look at the hands seriously here and get rid of the Dollar General stuff on the counters and get something that's professional, that's going to protect our hands as well. There are two quick videos here that I'm going to show you. The first one is by Dr. Gerba, and again, the link is in your handout. And he is a professor here at the University of Arizona. And he's going to talk to you about these soap dispensers. Now, when we say bulk refillable, what we're using, even when we're using the Dollar General containers, even though that we may not necessarily be refilling them, we're still getting biofilm in them. You can get biofilm in those very quickly. All right.
You're most likely to come in contact with fecal bacteria with a refillable soap dispenser than anywhere in a public restroom. Because you really can't tell contamination's occurring. You can't see the bacteria growing in there. So you never really know if there's bacteria or not. That's why using a sealed soap dispenser is the way to go. Well, it's been found that really cleaning regular refillable soap dispensers doesn't really get at the bacterial problem because biofilms develop inside these soap dispensers. And even if you clean them and disinfect them, it comes back right away, the bacteria. As soon as you put additional soap in these dispensers, the bacteria start growing right away. Well, I think there's definitely a risk to people getting ill from refillable soap dispensers because you find bacteria in there that can cause eye, skin infections, and wound infections. So I think the probability is there. And of course, it's been demonstrated in healthcare facilities. So we know the potential is really strong for this to occur. You know, people are going in there to remove things from their hands and they're putting them on. They're trying to take off fecal bacteria by washing their hands, and they're actually putting them on. So in a way, it's an oxymoron. You're doing the reverse of why you're washing your hands. Well, I really think bulk soap dispensers should be regulated. And in fact, I don't even think they should be used. I think we really should go to sanitary seal soap dispensers that you can't refill all the time, because that would eliminate the problem of the growth of the bacteria in these dispensers. But I think it's really the responsibility of facility management is to put the proper type of soap in these facilities so people don't increase their exposure to large numbers of bacteria. The greatest exposure to fecal bacteria for many people may be washing their hands.
Okay, that's not an endorsement for Gojo, but it's an example of why we need to use a touchless system. So 1 in 4 refillable bulk soap dispensers is contaminated, and hands can have up to 25 times more germs after washing with contaminated soap. So eliminate the Dollar General stuff and go to touchless. And you'll find that many of these touchless systems are actually more cost effective in the long run anyways. So you want to go to something that is sensor control and refillable. These come, and this is just generic, but they come with antimicrobial soap and water. I mean, regular soap for soap and water. And then also this goes for alcohol hand sanitizer. So if you're using the same type of container and everybody's hands are touching the same and you're refilling them, also that's problematic. All right. So we want to make sure that we go to a touchless system. All right, foot sensors. This is just a good example. Here's a system where would be a great system. You're not touching the faucet handles, but they're using a Bed Bath & Beyond soap dispenser there that they're refilling, and that's never a good idea. Okay, wash your hands when they're visibly dirty after we touch contaminated objects before and after patient treatment. And we said gloves can complicate the situation because underneath those gloves, those pathogens are multiplying and dividing. We spoke about nails, keep them short, smooth, jewelry-free if you can, so that you prevent glove tears and contamination. Again, make sure you clean under your nails. Use hand lotions to prevent skin dryness. Check with your manufacturer for compatibility. PPE is where we're going next. So in PPE, of course, I'm speaking to the choir here, but we want to make sure that we wear a surgical mask or whatever your comfort level. If I was in a clinic right now, it would be an N95, but that's me. And I'd be wearing it all the time, by the way. And eye protection with solid shields or face shield. And I forgot to mention the story about the hospital, the nurses back in September that weren't washing their hands. I went home and was exposed to COVID during my stay and developed COVID 3 days later. And I had COVID for 12 weeks. I had the 100-day cough. Many of you may have had this cough with COVID, right? The 100-day cough, and then got up one day and it was completely gone, like it never happened. So COVID is very much still there. All right, face shield. Face shield is an excellent way to protect the mucosa, your face. Again, we were talking about aerosol. We're talking about spatter. You don't want this on your face or hitting your face. I remember when we were a dental assistant without PPE, I could feel the pings of amalgam bouncing off my face while we were treating patients. We're going to change our mask between patients, or if the mask becomes wet, if you're wearing an N95, you can wear a medical grade mask over it and change that mask. And then your facial protective equipment was really meant early on to be disposable, those plastic shields. Now you can disinfect those between patients as well. We had a question from someone about what face shield should we use with loops. There are different models out there now available. Some of them actually are designed quite well because they can be far out and they can be too low. So check with the manufacturer, see if there's some way that you can check with your distributor for the fit, but they do make those with loops now. Okay, protective clothing. It's really important that your forearms are covered. If your chair side and your forearms are not covered, all of the aerosol and the spatter, your forearms are highly contaminated, and I don't think you're washing up to your biceps, right? So you really don't want to be walking around with that kind of level of pathogen on your forearms. You're reaching over other patients. Not a good idea. So this is what you should look like chair side. It's not beautiful, but you have your disposable gown. Your gloves are up over the elastic, the cuff of the glove. All right. What about scrubs? Some of you are required to wash your scrubs at home, right? In some states, the practice has to, or the clinic has to provide you with clean scrubs. Whichever you're doing, understand this, your scrubs are still contaminated even though you're wearing a gown. If you are providing your own scrubs and laundering your own scrubs, here's what I'd like you to do. Have a plastic bag with you. Change from your street clothes into your scrubs at work. Change from your scrubs to your street clothes before you leave your practice. Put those scrubs in a plastic bag. Keep that separate from your other household laundry. And when you wash your scrubs, hot water and use laundry sanitizer. Lysol makes a laundry sanitizer. Clorox makes a laundry sanitizer for colored laundry. Wash them in high heat, and that will kill C. difficile spores. If you're washing your laundry with the rest of your household laundry, your children, not a good practice. All right. Shoes should be changed. So you don't want to wear your work shoes out into your vehicle and home. Bring your street shoes, change when you get to your car. Throw those work shoes in a bag and keep them, tucked away, or leave them at work. Or wear shoe covers. Shoe covers are surprisingly inexpensive, and they're one of the best things you can do in your practice, because you don't want folks bringing things in from the outside either. We just heard a whole litany about C. difficile. C. difficile contaminates floors. And so we want some way to not take it home with us. When I had C. difficile, I had to have my vehicle treated, my house treated. We're going to talk about what these companies use to treat homes and hospitals for C. difficile contamination. Before you leave your operatory, you remove your PPE, right? Your gown should be changed at least a couple times a day. And for you hygienists, if you're using an ultrasonic scaler and it's, 2 quads of scaling and root planing, I'd think about more often than just twice a day. Okay, we spoke about gloves earlier. Medical gloves should be worn unless we're performing surgery. Then we're going to wear surgical sterile gloves. We don't wash our gloves. We don't disinfect them, and we don't sterilize them. Sounds kind of crazy, doesn't it? Well, it was. 'Cause 1981, that's exactly what we did. We autoclaved our gloves for surgery. Autoclaved our surgical gloves. So when I was a dental assistant, normally I wore no gloves unless we were performing an extraction. I got one glove, wore it on the left hand, and that glove went into a chemclave, or a Harvey, called Harvey. Wear appropriate gloves for cleaning instruments, housekeeping tasks. We're going to use nitrile utility gloves that are puncture and chemical resistant. And oftentimes now those are autoclavables, so you can autoclave them. And if you're sharing them with others in the practice, just slip on a pair of regular medical gloves and then you're okay. All right, you're going to probably see this on the quiz. So double gloving during oral surgery procedures. Studies show a lower frequency of interglove perforation, but the CDC believes we don't have enough evidence, so they've called it an unresolved issue. Contact dermatitis and latex hypersensitivity, we touched on a little bit earlier. Your emergency kits should be latex-free. You want to be sure that you have a latex-free environment if you can. Some of your patients may have a latex allergy. I think in all the years that I practiced clinically, we have had 2 that I knew of that had an actual latex allergy that was respiratory, but it's a type 1 hypersensitivity to the natural rubber latex proteins. Okay, let's talk now about sterilization and disinfection. Okay, question here. What can we do at home for the soap contamination issue? I have countertop touchless ones, but I have to say I had those before because I was involved in some of those studies years ago. So I already knew the hazards. Yep. and they make countertop ones. Should goggles still be used with a face shield? It depends on your level of safety. I do, but I wear loops. So I've had things fly up under the face shield and get me. Yes, I love the booties. I love shoe covers. Christina uses OxyClean sanitizer powder, Lysol sanitizing detergent liquid, and Woolite for black clothes. Might be overkill, but I feel better about my laundry. That's great. Clove shoes are made to be wiped down with our disinfectants at work, so I only wear those now. The problem is the disinfectants you're using at work are sporicidal. So you're not killing C. diff spores. So the best thing you can do is wear shoe covers. All right, so sterilization and disinfection. So I'm going to start by showing a video. I want to tell you all that part of my job from time to time, I would have to be a guest with the dental board and go and inspect dental practices. And here's what I want you to understand. And I'm not an attorney. If you're practicing in a situation that's not safe, if you're being told to do things that you know is not safe, and we didn't get to hand pieces yet, like for instance, not autoclaving your hand pieces, wiping them down with CaviWipe. And that includes your hygiene motors. Okay, that's not compliant. If you're being asked to do things that you know is not compliant, you're putting yourself at risk. You're putting yourself at risk for disciplinary action and worse. All right, so again, understand who's telling you to do these things. Go to management and make a request that there's a change. If you know that your autoclaves are not being tested, go to management first and ask them to bring it up to par. If it's not, then you have a couple of choices, right? The problem here is that all of us are on our honor to report things that we see. There are no agencies that will come in routinely and inspect dental practices. So the states require you to be the eyes and the ears. And if you don't report it and somebody else does, and you are found to be in front of the Attorney General trying to explain why you continued to use the instruments that you didn't know were autoclaved, you might not be practicing any further. And it doesn't matter if you're an assistant or a hygienist or a dentist, right? Associates are even greater risk. So I'm going to show this video to you. And this was the dentist in Ohio. He was an oral surgeon for 40 years. And I'll let them tell the story here. And every one of those employees found themselves with a disciplinary action and an allegation from their state attorney general. So it doesn't save you to say, well, it doesn't matter because I don't own the practice. It's the dentist. You are at risk. And we have to do the right thing.
Health officials are saying that a Tulsa dentist may have exposed thousands of patients to life-threatening diseases ranging from HIV to hepatitis. ABC's chief health and medical editor, Dr. Richard Besser, is here with this disturbing story this morning.
It is disturbing. You know, I've spent my career in public health, and it's not hard to prevent infections in dental offices. But what they found here was absolutely shocking. Dr. W. Scott Harrington has been a trusted oral surgeon for 36 years. But now authorities believe he may have exposed thousands of patients to potentially deadly infections by allegedly using rusty instruments which weren't cleaned properly. Letters are being sent to 7,000 Oklahoma patients recommending they immediately be tested for hepatitis B, hepatitis C, and HIV after one of his patients with no known risk factors tested positive for hepatitis C. In addition to allegations that he cleaned his instruments by improperly bleaching them, which caused them to become porous over time, he's also accused of reusing needles and vials.
The instruments that came out of the autoclave were horrible. I wouldn't let my nephews play with them out in the dirt. I mean, they were horrible. They had rust on them.
He even reportedly had medications 20 years past their expiration date and allowed unlicensed assistants to give IV medications. We reached out to Dr. Harrington, but he did not return calls.
So 7,000 patients have gotten these letters to get tested for HIV, hepatitis C, hepatitis A. I mean, what are the chances more patients are going to test positive, given those conditions?
Yeah, I mean, there are a couple of disturbing factors here. Many patients in his practice have HIV and hepatitis C and hepatitis B.
He was treating a higher risk population.
He was, and he had instruments set aside for those patients and other instruments for patients where he didn't know that whether they were infected or not. That's very dangerous. All instruments should be treated the same. Last summer there were 8,000 patients from Colorado who were notified, and thankfully none of them were infected. Here, there's a much higher chance someone could get sick.
But I would have thought soaking instruments in bleach would have killed anything. We keep hearing bleach is the only thing that kills everything.
Well, for a lot of things, bleach is the way to go. But these instruments have to go into something called an autoclave, which uses pressure and heat. If you use bleach on them first, it disturbs the outside of the instrument so that the autoclave no longer works.
And they become porous and things can get inside.
They can seep in, and then the heat and the pressure don't kill those germs.
So what are you supposed to look for, Rich? I mean, I go to a dentist office, and usually I've got so much stuff in my mouth I can't see what's going on.
A couple clues to look for. The first thing, if you ever see rusty or old instruments, that's a warning sign. The other is if your dentist isn't wearing gloves or isn't changing gloves between patients, find another dentist.
So he should do that in front of me?
Yeah, definitely. You should see that they're putting on fresh gloves.
Okay,
definitely.
and pay attention to those instruments.
That's
All right,
right.
Rich.
Preferably, you want to be washing your hands in front of the patient as well. So there's a big fail, and these things happen. And I've seen some things during my career, and I've been involved in some things during my career where I've had to report things, and it's not pleasant, right? But you have a duty to report. If you see something, say something, because you're the eyes and ears of infection control for your community. And if you know that instruments aren't being properly autoclaved, etc., it's putting your patients at risk, and it's also putting you at risk, right? So where do you report it? You start with your dental board. But I always go to management first and see if they're going to take care of the situation, right? If they're not going to take care of it, then you have a duty to report it. All right, a couple of questions here. For putting loops on, do we have to switch gloves? How to clean loops? So I would put my loops on before patient care if I can. If not, then you need to make sure after you touch those loops that you wash your hands and put on gloves. Yeah. How to clean loops, check with the manufacturer. Cordless electric hygiene motors. So anything that is attached to your air water should be autoclaved, because internally there is the potential for biofilm and other organic matter, etc., within those handpieces. When I was an assistant, back when dinosaurs roamed the earth, we wiped our handpieces off with a 2x2 and alcohol. That was it. And then we ran lube oil through them, and they were a mess, right? So you do have to autoclave. Now, in terms of your electric hygiene motors, not all of them are 100% autoclavable. So check with your particular manufacturer. Always on any of these devices, you should be following the manufacturers. And if somebody got, let's say they found cases of, as we'll see from a water line, non-mycobacterium tuberculosis was linked to these dental clinics in Irvine, California. It was found out that they weren't testing, treating, and shocking their lines. And so these children were developing odontogenic infection from that, right? There's a way to trace this stuff. If they come back and they start interviewing you and they say, well, why did you not shock the lines? Well, I didn't know I was supposed to shock the line. I didn't know, nobody told me to, etc. That's not going to be good enough. That's why you're required to take infection control courses. That's why you're required to report this. Whatever you see, it's not correct, right? You have to report it. You are the eyes and the ears. Wiping down a prophy motor instead of autoclaving it between patients. You have to autoclave your prophy motors, anything attached to air water. Is it an OSHA violation? It's an OSHA violation. It's OSHA protects the employee, but it's also probably a state statute violation because it's putting your patients at risk as well. OSHA would be something that's putting you at risk. So when you're handling dirty instruments, that is a risk factor for you. How do we sterilize the silicone brushes used for composites? So you're going to have to take a look. Some of those are disposable. They're not autoclavable. So take a look at your manufacturer. Christina, or is it an OSAP violation? OSAP is a private endeavor. It's not a public agency. So there's no such thing as an OSAP violation. You have your Dental Practice Act. All dental practice acts, for the most part, for your state, align with the CDC recommendations and whatever OSHA requires. It's all there for you, and you're expected to know this. And when you relicense or you license for the first time, you are signing an affidavit that states you will follow your Dental Practice Act and you'll report violations. So if there's an allegation like Dr. Harrison and you were part of that and you went along with it, you're going to have an allegation filed and you're going to end up in front of the Attorney General's office. So it happens, and it happens all the time. So again, start with your dental board, and we'll get to packaging in a minute. Gina, I'm not sure I'm following you on that one because there's, I think, some typos going on. Maybe you can clarify. Is it okay to use color tape band on instruments even if we're processing the instrument and pre-soaking the ultrasonic cleaner than autoclaved? I see them get pretty gummed up. I mean, there's the plastic rings too. So I'm not a big fan of them, but I've used them. You know, so the silicone rings, I prefer more than the tape. Okay, I'm going to hold off the questions on water lines for just a few minutes. Sterilization and disinfection. This is Spalding's classification of instruments: critical, semi-critical, and non-critical items. Critical items, high risk for infection because they penetrate the normally sterile tissues of the body, soft tissue or bone. Semi-critical items do not contact soft tissue or bone, but they do contact the mucosa, the non-intact skin, or other potentially infectious materials. And the non-critical items, these come into contact with soil, debris, saliva, blood, OPIM, not the sterile tissues, not the oral mucosa. So what are we talking about there? Let's take a look and break it all down. Critical instruments here penetrate, we said, the normally sterile tissues. We always autoclave these when we can, or we use sterile single-use disposable devices. What could these be? Surgical instruments, scalpel blades, periodontal scalers, surgical dental burrs. In the case of semi-critical instruments, these come into contact with the mucosa. They don't penetrate soft tissue. We should always autoclave when we can versus high-level disinfect. All right, always autoclave when you can. Now, the examples here, I don't completely agree with the CDC because they've included dental handpieces here. Because dental handpieces have to be autoclaved. Full stop. We can't just use cavity wipe and keep reusing the handpiece because, again, internally, the handpiece is contaminated and there could be biofilm. But dental mouth mirrors, amalgam condensers certainly fall in the realm of semi-critical instruments. Non-critical instruments would be your blood pressure cuffs, your pulse oximeter, face bows, x-ray heads, and you can clean and disinfect using a low to intermediate level disinfectant. I'm going to be talking to you today about hypochlorous acid, which is very effective on all surfaces. OPIM means any one of the following, and there's the breakdown for you. Anything plus blood, so saliva, cell, tissue, organ cultures, etc. All right, sterilization and disinfection of patient care items. We use only an FDA-cleared medical device. If you're buying your autoclave off of eBay, it should be FDA-cleared, right? That is in probably your state Dental Practice Act. Clean and heat, we spoke sterilize critical dental instruments, clean and heat, sterilize semi-critical items. Allow your packages to dry thoroughly before you handle them, because you can create micro tears trying to pull out a damp package. Use heat-stable semi-critical alternatives when required. Reprocess anything that may have become open, or the packaging, the integrity of the packaging could have been compromised somehow. Single-use disposable instruments are acceptable if they're used singly and they're thrown away appropriately. We don't use liquid chemical sterilants or high-level disinfectants for environmental surface disinfection or as holding solutions. Ensure that non-critical patient care items are barrier protected or cleaned, or visibly soiled. Clean and disinfect after each use with an EPA registered hospital disinfectant. And I'm going to talk to you about EPA List K today, which is a disinfectant that kills Clostridium difficile spores and everything else we need to be worried about. Right now, you are probably using List N, which includes SARS-CoV-2. List K includes SARS-CoV-2, MRSA, HIV, hepatitis, everything plus Clostridium difficile spores. And you can go to EPA List K and you can check the label on your product and see if the label is on the list. If it's not on the list, it's not going to be sporicidal. All right, this is a Yelp photo, and this was a patient. I'm going to remind you all, if you walk out of an operatory, cover your tray with a patient napkin, because they get curious. Sometimes you'll have missing instruments. You might have a missing handpiece. Cover your trays. This patient took many photos that were posted on Yelp, 38. This was from 2 years ago. And this is a rusty burr holder, and I believe it was a root canal. And here's another photo. And you can see, no rubber dam. Got a composite syringe laying in the middle of the mess with a dirty, dry angle on top of it. There are the canal lengths there. It looks like it was looks like they were struggling there, right? That looks to me like somebody was really struggling. But at the same time, what's of concern? Well, the tray has a tray cover on it. That's a good start. They've got a barrier protection on the unit device control. The air water syringe has a barrier on it. If you unscrewed that syringe and looked in there, it would be disgusting, and all of them are. The hoses are laying on the floor and they're filthy dirty, right? And when you see dirt, that is a substrate for pathogens. So you sometimes have to scrub the dirt off first. Well, you always have to scrub the dirt away first. You might take some elbow grease before you can disinfect. The disinfectant's not going to reach it with all that dirt. If you've got lines laying on the floor, sometimes it's because of the way your office is set up and it's the only way you can reach the patient, right? Then they have to be barrier protected. Instrument processing areas should be divided spatially: receiving, cleaning, decontamination, packaging, sterilization, and storage. We store sterile instruments in a different area from contaminated instruments. Minimize handling of loose contaminated instruments. Use automated cleaning equipment like an ultrasonic cleaner. Work practice controls to minimize contact with sharp instruments. We wear puncture and chemical resistant utility gloves, heavy duty, and wear appropriate PPE. For preparation and packaging, we're going to use an internal chemical indicator, use a container system or a wrapping system that's compatible with the type of sterilization process you use that has FDA clearance. Always inspect your instruments for cleanliness before you wrap them and autoclave them. Unwrapped instruments. We don't sterilize implantable devices unwrapped, and we don't store critical instruments unwrapped, and we have to handle them in a sterile fashion. Storage area for sterilized items and clean dental supplies. As said, we are going to store these separate from contaminated. Some states require you to label the packets, either date related or event related. So date related, you are going to stamp it or label it with the date that it was autoclaved and the autoclave that it came out of. And that state may require you to re-autoclave those every 30 days if you haven't used it. Event related means in that state, they're okay until there's a tear or rip or the tape falls off the package, and then we've got to reprocess. And we start over with ultrasonics, and then we autoclave. All right, sterilization, monitoring, use mechanical, chemical, and biological monitors. Now, I want to tell you that when we do autoclave or we monitor our autoclaves, we're doing this because it is telling us, hopefully, that our instruments are actually sterile when they come out of the autoclave. Otherwise, you could have an autoclave that's not working properly, and you wouldn't know. The tape on these packages, you could put them out in the car in Phoenix, and they're going to turn colors, all right? So that doesn't necessarily tell you that my car is sterile. So we want to make sure that we're using, and there are different tests available. I prefer spore testing in office because then we know we can put our instruments back into service. If you're sending a strip somewhere and you're waiting for the results online, and you've already put those instruments in service, they may not be sterile, right? You should monitor your autoclave at least weekly. If you're autoclaving many more instruments than normal practices, like here at the clinic, we had to monitor daily because we're processing several thousand instruments a day. And you may see that on your quiz. All right, so my perception here, when I had to inspect dental practices, the very first thing I did was I looked at their autoclave, because autoclave's the workhorse here. And if it's not being maintained, it's going to tell me I need to dig a little deeper everywhere else in their sterilization process. So these are statums, and this is mold growing in these devices, right? Because they haven't been maintained. So if I open an autoclave door and I see mold growing in the vinyl, I know we've got an issue. What do you need to do in terms of maintenance? Assign it to someone who's in charge. They're going to perform the daily maintenance, the weekly maintenance, the monthly maintenance per manufacturer's instructions, and then you're going to send these out at least yearly for a tune-up. Whatever company you use can leave you a loaner. What they'll do when they do these tune-ups, they're going to check the gaskets, they're going to calibrate the temperature, the pressure, they're going to clean it. It's going to extend the life of these devices, which are expensive. Autoclaves are expensive, but they have to be running correctly, right? So this is a great investment, but you do have to make sure, assign it. I was in a situation once where they weren't monitoring the autoclaves at all. So I happened to be working on a patient. I turned around, I see an autoclave flashing error at me. It's a little child. And I asked the assistant, are these instruments sterile? Well, yeah, doctor, they came out of the autoclave. I said, that autoclave's saying error. I said, let me see your maintenance records. They didn't have any because they weren't testing their autoclaves. So I had to go to the lead dentist, and guess what they had to do? They had to shut the clinic down. They couldn't demonstrate that their instruments were sterile. How many of you are in situations like that right now? I bet quite a few of you, right? If you see something, you have to say something. You can't just go on the goodwill of people and say, okay. It could be your little child that you're subjecting to an infection too. Okay, recommendations for positive spore test. What happens? Well, you have to repeat it. If it comes back positive again, then you're going to have someone take it away and repair it. When it comes back to you, you're going to challenge it with 3 test empty chambers, right? And document all of it. Any questions? Let's see here. When using a statum, is it okay to take instruments out while they're air drying? Should we wait until they're completely done? In some cases, if you're able to pull the whole tray out and let them dry, that's fine. But if you're trying to pull a package out while they're drying, no, that's not okay, because you can create micro tears. We have multiple front office staff who've worked clinically to support hygiene with turning over rooms and processing instruments and sterilization. OSHA requires classification employees based on their dental office roles, but unless they are licensed, they are not required to take infection control every other year. Has there been any changes for the support office whom are not licensed but provide a dual role? Depends on your state, Gina. Yeah, depends on your state. Some states aren't even required to take infection control. So the role gets even more complex, right? But it's much more complex than that. So here's the issue here. In some practices, everybody's in charge of infection, or everybody's in charge of processing instruments. So whoever has time goes back and processes instruments. There has to be really one designated person that oversees and makes sure that everything that's being done should be done, and everybody needs to be trained. If you have your front office staff, for instance, involved in your autoclaving instruments and so forth and turning over rooms, everybody should be trained to the same level. If you have your front office person running to the back, wiping down your operatories with Cava wipes so you can get that root canal in there, and they've never been formally trained, I do have a concern about that. I do. Not just for the patient, but also for the front office person. The companies that recommend for autoclave yearly tune-ups. So if you are working with a distributor right now, they can help you with that, or call the company, the autoclave that you have, and they can also tell you. I don't have a particular spore detection system, but I do like the ones that are in office, and there are ones now that are more rapidly able to tell you the results. So cassettes. So I do like cassettes. The cassettes need an internal indicator, even if they're in a bag with internal, external indicators. I'm not sure I'm following you, but if you're processing them and you're wrapping them in autoclave tape, that should be sufficient, unless you are processing implants. Okay, environmental infection control. I'm going to hopefully change the hearts and minds of you all as we close here to consider using something other than what is called quaternary ammonium compounds. So if you could go ahead and type in the chat area, and again, this is going to be anonymous, what disinfectant you're using right now on your countertops, for instance, and your units. Go ahead and type it into the chat area. Okay. So let's go ahead and take a look. The majority of you right now are using Cava wipes, which are great products, but they're quaternary ammonium compounds. They do what they're supposed to do. They're not sporicidal, and they've been found to actually cause more cross-contamination of Clostridium difficile. The wipes, right? Not specifically Cava wipes, but the microfiber wipes and quaternary ammonium compound solution has been found to create more C. difficile spore contamination because it doesn't kill the spores, it moves them around. In your course folder, you're going to see a document that I want you all to look at on quaternary ammonium compounds and their risk. They're very toxic. There was a study, a peer-reviewed journal in the summer last year showing that quaternary ammonium compounds, the concern here is fertility, immune system, respiratory system, asthma, and the concern is that they're not well regulated. So we have an alternative here. It's hypochlorous acid. When used at sufficient concentration, will kill everything that we are concerned about. It is non-toxic. The body produces hypochlorous acid, but it has to be in the right concentration, the right strength, and the right pH. Those of you that may be producing this in a countertop generator, you're not producing hypochlorous acid at a concentration that will kill C. difficile spores. My recommendation is NADCC tablets, and I'm going to show you how that looks here. I'm going to show you the demonstration. Why are we concerned again? We are worried about contamination, and mostly Clostridium difficile. So I'll show you a quick video here. And this is an electrostatic sprayer and hypochlorous acid. And this person using it is not wearing PPE. We wear PPE, all right? But you're going to see the ease of use. He's using it on all surfaces. You go into a grocery store, you know how the misters come on? You can smell a very faint smell of bleach. That's hypochlorous acid. And they use countertop and huge generators to make their own hypochlorous acid. That is food grade hypochlorous acid. What you don't want to do today is go to Amazon and buy any hypochlorous acid and have it shipped to you, because it's probably not going to be the right concentration. All right, so let me show you what he's doing here. The electrostatic sprayer charges the molecules as they exit the nozzle. So it provides an even coating of the hypochlorous acid. It's evenly distributed. Notice he's going right over the glove box, the phone, the blood pressure cuff, the infusion, the IV device. He's going to go over the chair. This is a hospital, by the way. He's going to go over the chair. All the electronics. So hypochlorous acid used in this manner can be used on every surface in your dental practice. Your electronics, hypochlorous acid, the NADCC tablets come in two forms. One to use in the sprayer, like you see here, and one that has detergent that's been added so that you can use it with dry wipes, not microfiber wipes, on your high touch areas, your dental chair, countertop, and then you come in with the electrostatic sprayer. The solution needs to stay in contact with the surface for 4 minutes. The concentration is 4,306 parts per million. If you are making it in a countertop generator, you're probably at 200 to 300 parts per million. And in many cases, it's not considered EPA or EPA registered. So if you had an outbreak in your practice and you were using something that was not approved, you're going to have a hard time defending yourself. So using the NADCC tablets with the detergent can also be used with mop heads on the floors and other high touch areas. All right, so when we're talking about environmental surfaces, we're talking about clinical contact surfaces and housekeeping surfaces. Clinical contact comes into direct contamination with the patient and sprayer spatter or our gloved hand. Housekeeping surfaces, everything else. Countertop, flooring, walls, etc. Now, the CDC believes there is limited risk of disease transmission, but we have to be concerned about aerosol, we just saw. So you can have aerosol that attaches to your wall. That's not necessarily limited risk of disease transmission, right? Okay, so looking at clinical contact areas here, we're looking at the light handle, the unit handle, the patient chair, and housekeeping surfaces, flooring, countertops, faucet handles, etc. I would like to say in terms of aerosol, you want to remove everything you can off your counters that you don't need. All right. So environmental infection control, we follow the manufacturer's instructions. We use an EPA-registered hospital disinfectant, use PPE. Even though hypochlorous acid is non-toxic, we still wear PPE in our practices. We cannot combine it with Cavicide. So if you go with one, you've got to stick with it. And again, I want to emphasize Cavicide wipes have been used for a long time. They're on EPA list N, but they're not sporicidal, and there is some concern about toxicity, and the industry has known this for a long, long time. There's also another document in your course folder by Dr. Rella Christensen and Dr. Gordon Christensen on why they've given up on wipes altogether. They don't believe they're effective. All right, clinical contact surfaces, again, we either barrier protect using surface barriers or surface protect using barrier protection. And we're going to clean and disinfect clinical contact surfaces that are not barrier protected with EPA-registered hospital disinfectant. And hypochlorous acid can be used on all of those surfaces safely, effectively, cost-effectively, and you're going to kill everything you need to kill. On EPA list K, some of the other disinfectants you'll see is hydrogen peroxide at a particular strength, but it can fade your surfaces. Bleach, which is often used in hospitals. Many hospitals now are using hypochlorous acid. Dr. Palmier, who teaches our antibiotic course from the American Dental Association, discontinued using quaternary ammonium compounds. They use hypochlorous acid. All right. This is another Yelp review. This is a chair that's been duct taped. Chair cover, though, or headrest cover, but duct tape. The chair is filthy. You can't disinfect that chair. And you have the notation here from the patient. The place is nasty, dirty, equipment is outdated and old. And these are the reviews. These are what patients are looking at. Housekeeping surfaces, again, floors, walls, sinks. We're going to use a detergent and water-based EPA-registered hospital disinfectant. Hypochlorous acid, NADCC tablets that are made for the job. And you can make a solution, put it in a bucket for the floors, used on the walls, wherever you need to use. That you need to consider high-touch areas, anything that is visibly soiled. Now, if you're using a housekeeping service, find out what they're using. If they're using Mr. Clean on your floors, that is not effective, right? So disposable mop heads should be used. If they're using the same mop head in the gastroenterology office as they are in your practice, you're in trouble. And do a surprise inspection sometime when they're in your office cleaning. Find out. All right, spills of blood and body substances, hypochlorous acid, carpet and cloth furnishing, hypochlorous acid. You could treat your reception area at lunchtime and at the end of the day with the electrostatic sprayer. Again, does your disinfectant kill Clostridium difficile spores? Should be on EPA list K. If it's not, it doesn't. You saw the video on managing community onset. You saw the video on hypochlorous acid. That is representative of a sprayer. So you drop 4 tablets NADCC in 1 liter of tap water. Let it dissolve in a few minutes. You just plug this gun in and get it charged up, and away you go. What also is great is that you'll cover 30% more surfaces by using a sprayer because those charged particles create a wraparound effect. So if you're using just a spray bottle, you're only going to hit the surfaces that you can reach. This actually wraps around to the back of the device that you're trying to disinfect. This is a course I present on effective surface decontamination, and you can check the website for upcoming dates. And again, I also present a course on hypochlorous acid. If you have any questions, you can reach out to me. The company that makes hypochlorous acid NADC tablets would be EvaClean or EarthSafe. Those are a couple of them. If you do a quick Google search, you'll see a few companies that come up. All right, let me take a look here. I know there's a million questions. So, no, I said in terms of the mask, we wear PPE. They're just demonstrating that it's non-toxic. Those of you that are changing your rooms and setting up your trays, many of you might have been trained to set up your trays with your bare hands in front of the patients, because the concern was if your gloves were on, the patient may think you're reusing the gloves. That's sort of changed. Wash your hands in front of the patient, put on gloves, and set up their trays. Clean hands on sterile instruments, not acceptable. You should be wearing gloves. Okay, we had a couple of you using hypochlorous acid. Yeah, hypochlorous acid made in the office. The concentration is not sufficient to kill C. difficile spores. So, and also the problem with the wipes is that you're turning over these operatories very quickly, and you're probably not leaving sufficient time for the solution to actually make contact with the surface. Inhaling hypochlorous acid. So hypochlorous acid is used in wound management. It's used in water lines. It's used in veterinary medicine. It's used in human medicine for all sorts of applications. But in terms of your surfaces, it has to be at the right concentration to be effective. Okay, regulated medical waste is regulated by your municipality. You're going to use a hazard bag, check with your local municipality. Dental unit water lines, biofilm, and water quality. So water lines have to be tested, treated, shocked, and retested. If you've not done that in your practices, you definitely want to do that. So test first, then treat. You're going to test again, all right? And then you should be shocking. And we have a course on dental unit water lines, so you can check with us and see the upcoming schedule. I go into much more detail. Discharge water and air for a minimum of 20 to 30 seconds after each patient. Even if you are using bottled water, there is retraction that occurs. And so biofilm will grow inside these water lines. The water lines are small in diameter. The flow is slow. So, and the tubing is just conducive to biofilm growth. Right? You should be using anything that meets EPA regulatory standards for drinking water. So less than 500 colony forming units of what's called heterotrophic water. That will be okay for routine dental treatment if you're using tap water, but again, you still have to test these lines. The same for bottled water. This was an outbreak of non-tuberculosis mycobacteria that I spoke of earlier, and they weren't testing their lines, and children became infected. And they became infected in some cases a month or so after they actually had their appointment. Boil water advisory. If you're in an area where the water is not safe to drink, not potable, then it can't be used in your unit, and you'll have to follow your municipality's instructions. I was practicing somewhere where a raccoon fell in their well, native health. So we couldn't see patients until they fixed the water situation. We did not have bottled water. Special considerations. Dental handpieces, we said, must be autoclaved. If you're using electric prophy motors, check with your manufacturer. Dental radiology, all of this, hypochlorous acid. So barrier protect what you can, and hypochlorous acid is excellent for this. And always check with your manufacturer. I'm not going to go into detail on parental medications, but it's there for you. Single-use disposable devices, use once, dispose of them appropriately. Pre-procedural rinses we spoke of earlier. The CDC believes it's an inconclusive situation. However, if you look at the studies tell us otherwise, and the CDC admits that. So again, take the class that we have on oral rinses. Oral surgical procedures, surgical hand antisepsis, surgical sterile surgeon's gloves, use a sterile saline or sterile water dispenser or device as a coolant. Handling of biopsy specimens, you're going to be transporting in a sturdy leak-proof container with a biohazard symbol. Handling of extracted teeth, we will autoclave. Dental laboratory, I can't think of a better place to use hypochlorous acid. It's all there for you, right? Impressions, you can also use hypochlorous acid before you send it off to the lab. Double check with your manufacturer of your impression material. Anything that can be autoclaved should be. We heard Dr. V's presentation earlier about electrosurgery plumes and laser plumes causing infection in the oropharyngeal area. These were actually HPV lesions that developed in the oropharyngeal area of gynecologists. Mycobacterium tuberculosis, two-step test, and make sure that you keep that up to date. Again, we spoke about credentialing software. Creutzfeldt-Jakob disease, other prion diseases. The CDC believes it is an unresolved issue. Program evaluation. It's important to take a look at your program and see if it's performing the way you want it to, if it's causing unintended consequences. Look at your injury reports, see if there is something you need to change. That is the link to List K. pH, as we said, is important, as well as concentration. If you use NADCC tablets, you're only shipping tablets. You're not shipping liquid, by the way. So it means it's cost savings to you. And when you look at these various systems out there, they're more cost efficient, and your storage space isn't taken up by huge tubs either, or cases of tubs. These are other courses that we offer. There's the oral rinses course that I was talking about, the C. diff course, surface decontamination, hypochlorous acid, effective hand hygiene, antimicrobial resistance. It's all there. Aerosol, we just had the other night, UVC technology as well. Our course coming up June the 7th, Dr. Paul Meyer, if you've not taken his course, again, he's with the American Dental Association. He's the co-author of the Antibiotic Prophylaxis and Therapeutic Use Guidelines. The course is at no charge. It's the last time it will be offered no charge, so register for it, because we're going to be doing a 6-hour master class for you all, and there will be a nominal fee for that. So let your colleagues know about that course. There's the top 10 course we just had the other night. There's the link for you. I go into much more detail on the technology. November is C. difficile Awareness Month. We believe it should be every month. And that's me on the lower left. That was my 4th hospital admission from Clostridium difficile infection. I had multiple recurrent infections. Let's take a quick look at your questions here, and feel free to reach out to me through the website. There is the email. Just put my name in the subject line. I will get back to you. Extracted teeth. So they should be autoclaved, and can they be tossed in the isolator? You have to check with your local municipality. That's a local issue as well. EverClean and EarthSafe. So EarthSafe, just as it sounds, and it's EvaClean, EvaClean. If my office is only willing to use Cavicide spray and wipes, what else could I do on my side? Well, you can share the information with them, and you have a document in your course folder. And then you have to make a decision. You can't combine the two chemistries. Let's see. Hypochlorous acid electrosprayer can be used on all non-sterilized dental unit tubing effectively, then wait 4 minutes. So what you need to do, if your tubing's dirty, use the dry wipe with the EvaClean. It's called Pure One tabs, you'll see. And that has a little detergent in it. Scrub them down so they're clean, or change out your tubes too. If you can't get to a clear waterline test, by the way, you may need to end up changing tubes. Vacuum lines, that's an entire different course that I'm presenting and they're different. Your vacuum and your water lines are different. Your vacuum line is almost like the sewer system of your practice, right? Even when a product says it's a one wipe product, you still have to clean the surface first. Yes. Yes. So the wipes are called cleaner disinfecting wipes, meaning there's some detergent in there. But you and I both know that we're busy and we're turning over operatories at warp speed, right? So if we're going to do that, we need to use something that gives us more power to be able to do that more effectively, more reaching more surface, 30%. So again, you address your high touch surfaces, the chair, anywhere you see visible dirt. When you are using a housekeeping service, have them use hypochlorous acid and disposable mops. You can't go wrong. The EPA list of disinfectant levels, you can go to the EPA and there's a link to EPA List K, or take the surface disinfection course and I go through all of them. So as we close here, hypochlorous acid was used in foggers. Many of you at the early days of the pandemic, you were all breathing it. It's fine. It's fine, but we wear PPE, right? So many of you may still be using those foggers. Okay, everyone, thank you all for being here. If I did not get to your question or you want more information, reach out to me through the website. I'm going to now direct you to the quiz. So hopefully you all are here. So when I close out, you will be sent to the quiz. Complete the quiz. You can check your score and resubmit. So you don't have to resubmit and resubmit. Check your score. You'll see if you missed any. All right. Check our website for courses next week. Monday, we have Pam Cushionen. She's presenting on pathogens and systemic illness, periodontal pathogens. We have a whole bunch of classes next week. So I'm going to go ahead and close. Thank you all for being here. Here comes the quiz. And the quiz will be sent to you also from noreply@clickmeeting.com. Have a great day.